मैम वीकेंड लाइफ।
So, very good afternoon to everyone who has joined today. It is my real honor and privilege to have you all on this special webinar on Shakti, Triumph of Health over Diabetes, organized in honor of Women's Day, which is coming up on 8th of March. Today, we celebrate the resilience, strength, and well being of women while addressing a critical health challenge, diabetes. So, as we all know, that diabetes affects millions across the globe. In women, it may be a little different because it intertwines across all life stages with the hormonal shifts, pregnancy, menopause, and lifestyle factors. Yet, with the correct strategies, early interventions, and a patient centric approach, we can empower women to take control of their health and rewrite their diabetes journey. So joining me today, it's with along with Dr. Dhruvi Hasnani, we have an esteemed panel of diabetologists. We have Dr. Shalini Jaggi, Dr. Purvi Chawla, Dr. Lily Rodrigues, Dr. Nandita Arun, Dr. Lotika Purohit, Dr. Neeta Deshpande, Dr. Archana Sada, Dr. Manisha Gupta, Dr. Shifali Karkhanis. And with that, we have an esteemed panel of dietitians too. We have Dr. Kavita Gupta and Cheryl Salis joining us for this webinar, each bringing valuable insights into this diabetes care. Through this discussion, we aim to move beyond conventional treatment and explore a holistic, precision based approach to diabetes management in women. But here, we aren't leaving our men aside. Along with women, we want our men to be an equal part of this journey of triumph of health over diabetes, and we as we go hand in hand to move ahead to create a better, healthier, and a stronger future. So, beginning on this insightful session, I invite our first speaker, Dr. Purvi Chawla, to be talking on breaking the bias, women's health and diabetes. Are we doing enough? Can we have Purvi ma'am's slide, please? CV slide. Yeah. So it's my honor and privilege to invite Dr. Purvi Chawla, who is a consultant diabetologist and director of clinical research at Lina Diabetes Care, Mumbai. She has hordes of accolades with her, a national and an international level speaker, and with a lot of awards. Not taking much time, I invite you, Dr. Purvi Chawla, to start with your session.
Thank you so much, Ami, for that very kind introduction. And good afternoon, everyone. A big thank you to Dhruvi and a big shout out to the entire team that Dhruvi is leading today and also USV for facilitating this webinar. And she's given me a very complex topic and yet a very simple one. So, I'm not going to answer this question. I will talk to you and then I want you all to answer this question. And the question she's put forward is breaking the bias, women's health and diabetes. Are we doing enough? So, amongst non-communicable diseases, they are responsible for almost 63% of all deaths noted worldwide. And diabetes is one of the top ones, affecting especially Indian women. And these are the overall ICMR INDAP 17 study results which were published just 2 years ago. And you can see diabetes is at 101 million, much higher than what the IDF had predicted. And along with it, all the pre-diabetes states or all the states that contribute further to diabetes, like abdominal obesity, generalized obesity, dysglycemia, and all the other associated comorbidities are only increasing. But if you tease out that data and look at the divide between urban and rural and then men and women, you can see that not just diabetes, which dysglycemia, which includes diabetes and pre-diabetes, is equivalent in both men as well as women. But more astounding is the fact that generalized obesity, abdominal obesity, dyslipidemia, and in particular, low HDL states are much, much more significantly prevalent in females as compared to males. So this is the astounding way the epidemiology of NCDs is evolving in India. And currently, we definitely have women more prone to developing diabetes. In fact, if you look at these statistics by the IDF, comparing the deaths in males and females afflicted due to diabetes, you can see that it's equivalent throughout, but there's a whooping increase in the latter part of life in women as compared to men. So overall, it would not be wrong to say that women are more dying because of these NCDs and in particular diabetes than men are. Now, to understand all that, I think it's necessary to go through this slide and to understand the difference between sex and gender. Biological sex is nothing but something that which is determined by the genetic makeup and the hormonal influences, and it impacts the disease pathophysiology, manifestation, and also the response to treatment. But the gender constructs are the ones that determine the patient's perception to disease, the health-seeking behavior, use of healthcare, decision-making, therapeutic response, etc. Because this is what is actually the lifestyle, the smoking habits, the eating habits, the exercise or lack of it, perceived stress, all that is what is gender. And they also influence this entire they are the ones that cause the epigenetic effects on the biological sex, and that ultimately corresponds to how disease is going to manifest and how we're going to respond to treatment. In women in particular, like Ami said in her introduction itself, there are so many challenges at different aspects or different stages of a woman's life because of the hormonal shifts and because of the natural life cycle of a woman, which includes puberty, menstruation, the preconception phase, pregnancy, then the breastfeeding phase, perimenopause, menopause, and then the postmenopausal state. And just some reflections around that. Women's health in India is determined not just by the biological disparities in health behavior, but also by the prevailing socio-economic and cultural and political conditions that prevail. In fact, reproductive women, the most productive phase of life, they are at a higher risk of developing chronic disease and have adverse consequences, including poor pregnancy outcomes if not tackled appropriately. And because it affects the life course of mothers, being born to a mother with chronic disease increases the risk of undernutrition, delayed physical and cognitive progression, and perhaps even the rise of NCDs earlier on among children. The synergies of various chronic diseases can be ascertained not just by the age, but also by gender, by the education level, marital status, working status, and other behavioral aspects. And higher risk in those coming from lower socioeconomic categories and other characteristics such as the parity or number of children born and even the menopausal status. So gender can be a significant confounding factor as the prevalence of multimorbidity is much higher in women as compared to men. Looking at the global trends of obesity, and we just celebrated the World Obesity Day with Prime Minister Narendra Modi also giving it much deserved importance, the entire aspect of obesity, because it is the mother of all non-communicable diseases. And unfortunately, India is number 4 in terms of the prevalence in males, but number 3 as far as women are concerned. And you can see this whooping increase in overweight and obesity in Indian women. So this is astounding because this is further feeding into diabetes and everything else. but we are inflicted by the dual burden of malnutrition, which includes undernutrition as well as overnutrition. And they both seem to impact the development of obesity much more in women as compared to men, as seen by every study. Thus, the prevalence of metabolic syndrome also, you can see every study in India has reported a higher prevalence in women as compared to the men. The relationship between BMI, increasing BMI, and the risk of type 2 diabetes, again shown in green are women and blue are men. And you can see that for women, right from the BMI of 23 itself, the risk is gradually increasing, and then it's much, much higher as the prevalence of obesity or increased BMI increases. But in men, the inflection point seems to be 25. So we women need to be far more careful about overweight and obesity. Polycystic ovarian disease, again, a complex metabolic disorder which is very specific to women for obvious reasons. Again, marked by visceral obesity, hyperandrogenemia, and creating that state of insulin resistance, further manifesting into so many metabolic disorders, including type 2 diabetes, and all these further feeding into the cardiovascular burden, cardiovascular disease burden in women. In fact, a median follow-up of 11 years of a large meta-analysis did show us that the risk of developing diabetes was 4 times higher in women with PCOS as compared to the controls. The question is, how many pregnant women have hyperglycemia? And this is answered by these statistics given by the IDF, that hyperglycemia in pregnancy, and I'm sure Dr. Shalini will elaborate further on it, more than 16% globally, and 80% of them are because of cases due to gestational diabetes, and almost 22 million live births are affected due to hyperglycemia in pregnancy. Southeast Asia, India included, has the largest prevalence of hyperglycemia in pregnancy. And this is nothing to boast about, but it is something to take cognizance of so that we can accordingly tailor our management of it. And why is that important? Because over a genetic predisposition, if there is pre-pregnancy obesity and a state of insulin resistance in the mother, and further with gestational insult as well, this is going to make her child far more susceptible to cardiometabolic disease as other children who are born to non-gestational diabetes or non-obese mothers. And this is all because of the epigenetic modification or the fetal programming that takes place, which is influenced by the maternal nutritional imbalance and metabolic disturbances. And they have a persistent and intergenerational effect on the health of offspring and risk of diseases further as obesity, diabetes, and cardiovascular disease. Again, a very elegant systematic review and meta-analysis by Dr. Kamlesh Kunti, Melanie Davis et al. From the UK showed that the relative risk for type 2 diabetes was almost 10 times higher in women with previous history of GDM as compared to the healthy controls. So GDM is a pre-diabetes state. It is definitely going to increase your risk of type 2 diabetes earlier on in the post gestational period if not adequately intervened. Another systematic review and meta-analysis, again from a very, very reputed group, Dr. Ravi Ratnakaran and all from Canada, they found that the future cardiovascular events in women with previous gestational diabetes and the relative risk of that was 1.98. In fact, those who did not develop diabetes after even without diabetes, in case of gestational diabetes, there was a 56% higher risk for future cardiovascular events. And again, this study is very relevant to the Indian scenario because higher the parity, which is very much the case in India, higher is the risk of developing diabetes, as seen in the Singapore Chinese Health Study. Non-alcoholic fatty liver disease, again, that's gaining a lot of prominence, which is now called MASLD, or metabolic dysfunction associated steatotic liver disease. Again, it was found that pre-gestational diabetes and NAFLD or MASLD had a very strong relationship. And another cardiac study in 2016 showed us that women with gestational diabetes had a twofold higher prevalence of MASLD as compared to those without GDM. And risk factors of MASLD, you can see that they are all very, very specific to women and everything that we're dealing with women, not only the genetic predisposition, but all the metabolic syndrome, older age, higher consumption of sugar and high fat, sedentary lifestyle, menopause, whatnot. And again, to prove that, I can show you that the study even looked at comparing the amount of visceral fat that a man and a woman has when they are age matched. And you can see that one with diabetes at the same age and stage has far greater liver fat as compared to, a woman has far greater liver fat as compared to a diabetes inflicted male. And again, at menopause, this becomes even more with the ovarian senescence setting in and the estrogen deficiency, there's higher fat accumulation in the liver. So just naturally also we get more prone to developing MASLD, and diabetes just worsens that risk. Now, during menopause, because of the decreased sex hormones or decreased estrogen and the increase in the testosterone, there's definitely a shift in the entire muscle mass as well as body fat. And there is increased central deposition of fat, increased inflammation, and all that along with the vasomotor symptoms impact the glycemic control completely and throw the woman off her track of good glycemic control, making her even more susceptible to cardiovascular disease. Early menopause and premature ovarian insufficiency are also very closely associated with increased risk of diabetes as compared to the controls. And you can see that the liver lipid profile is so badly disrupted at menopause, with HDL levels going really down and LDL going exponentially high at menopause. What are the consequences of diabetes in women? Well, all microvascular and macrovascular complications occur both in men as well as women. But as far as neuropathy is concerned, again, higher prevalence amongst women as compared to men in Asian populations, as seen in some studies. And even renal function may decline much faster, even though the prevalence may not be higher in women. The decline is much faster in white Caucasian postmenopausal women as compared to the age-matched women. I'm sure if we did more Indian studies, we would find some more alarming facts about diabetes and microvascular complications. Now, this is the classical slide that we always want to share when we want to show you the cardiovascular risk in diabetes. And clearly in men, it's increased. It's twofolds more. But look at the increase in women. It's 4 to 5 times higher in women as suffering from diabetes as compared to men. And all meta-analysis further just support this, what the Framingham study classically showed. Not going into those details, even the risk of stroke is 24% higher in women as compared to men. And smoking and CHD, again, smokers have early onset of heart disease, and also their protection from the hormones is almost obliterated when they have diabetes as well as smoking as a risk factor. Again, gender differences in terms of diabetes and depression. Women experience far more depression, or twice as more depression as men do. And again, there are so many contributory factors to the same. And sexual dysfunction, almost 68, 69% of females with diabetes experience sexual dysfunction. We never talk about it in the clinic. And that is one of the fallacies, and it must be taken up very, very strongly, because women do have an equal right to enjoy that sexual function which we are blessed with. Trends in osteoporosis have shown that, yes, as compared to a person without diabetes, definitely bone health is declining much faster in those with diabetes. And when you look at men and women, the graphs are completely different. Look at how poor the bone health is, or the bone mineral density is in women as compared to the men. Similarly, the association with cancer, again, far higher prevalence of cancer in women with diabetes as compared to men. So why all this inertia to prevent diabetes? Because a majority of the cases are preventable. And if you look at the entire list of barriers, and many authors have, classified it in several different ways. But if you look at the personal barriers, most of them say that there is lack of time due to caregiving role and other work schedule that they have. Women definitely seem to give less priority to their own health. And the health system barrier, which we can impact, is that there is failure to provide adequate health information to women, and unsupportive nature of health professionals or trained health professionals, or those looking at specifically women and diabetes, don't know that it is different. So gender inequality exists, there's pay inequality, there's decision-making limitations, there's healthcare expenditure, drug costs, doctor consultations, lab tests. All those are prioritized for men as compared to women. And again, so all these, and even in terms of nutrition and education, healthcare related education, women have far less opportunities as compared to women, as compared to men. In fact, clinical trials itself, and this is a massive, I mean, this can be a paper by itself, that there is underrepresentation of women. We are writing all the guidelines based on evidence, and then there is hardly any evidence in women, because clearly, whether it's heart failure, whether it's coronary artery disease, whether it's diabetes, what have you, there are lesser women enrolled in these trials as compared to men, and we just look at the evidence and publish the guidelines. In fact, new lipid medication added is also much, much lesser in women as compared to men. Even the use of aspirin is much lesser in women as compared to men, and I can show you tons of studies with respect to that. So there is therapeutic inertia, and those who have studied it formally, especially the inertia study, showed that the percentage of high and very high therapeutic inertia was significantly higher in women as compared to men. So look at, besides all this that I've shown you, there are these amazing social determinants of health which have also been studied in the South Asian setting and are very much relevant to the Indian setting. And you can see that whether it's childhood experiences, employment, housing, education, social support, community support, or even access to healthcare, everything impacts women and the manifestation of disease and response in them as well. Again, digitization may be helpful, but probably not so in case of women, because who are already burdened with work. And then we are introducing one more complication and making their lifestyles more sedentary. Physical inactivity, yes, Indian women top the list. Especially in terms of recreational physical activity, is the poorest in Indian women as compared to any other population in the world. And all this is transgenerational. I don't have to explain this to you, but an unhealthy mother will give rise to an unhealthy child who goes on to become an unhealthy mother again in her lifestyle, in her life cycle. The non-communicable diseases module for multi-purpose workers, I looked this up, and where they reflect on non-communicable disease increasing, and look at what they are acknowledging for women, that women are particularly disadvantaged as often, and they are more vulnerable because of their status within the family and society. I mean, this is really a matter of shame that we are acknowledging it. Our government is acknowledging it, but yet we are not able to combat it. The stigma, the diabetes stigma that Dhruvi also wanted me to cover, far more in women as compared to men. And we can again talk for hours with respect to that. But let me conclude and really say that diabetes in women is different, difficult, disabling, dismissed, and with more death. And I must say that I am quoting this completely from Dr. Usha Sriram, who is a champion of women's health in India. So the conclusion, now you tell me, you know, really women's health and diabetes, are we doing enough? And I think that that question mark gets converted to an exclamation because we know that we are not doing enough. So with that, I thank Dhruvi and Vipul for this excellent opportunity. But please remember, we have no time to lose.
Thank you so much, ma'am. It is really interesting. Love the cartoon that I'm standing in the middle of the room, and yet, I feel invisible, and a lot of us have gone through that. Thank you so much. It was wonderful. Can I also request you and Shalini ma'am to continue on the next panel? Unfortunately, Lily ma'am is running a little late, and she's occupied somewhere. So, if I have both of your permission to, continue with the panel as well. We've had the opportunity of having this platform today so that we can come together and talk about women healthcare, not just on International Women's Day, but all across, all through the year as well. So with that, I'm going to thank you for a wonderful deliberation and to start our today's webinar. And I welcome Dr. Archana Sarda ma'am from the city of Aurangabad, the senior most clinician. She's done ample amount of work with type 1 diabetes as well as with type 2 diabetes. Along with her, we have Dr. Manisha Gupta. She's from the city of Kanpur, a young budding diabetologist. She works a lot with sexual dysfunction, endocrinology, and technology and diabetes. We're waiting for Dr. Lotika ma'am as well. I think she's facing some trouble. Just because so that we don't waste time, I think I'll start with the panel questions, and I'll start with Archana ma'am. If Lotika ma'am is here, she's going to live 100 years, and all kudos to that. Lotika ma'am is our senior clinician, physician, and diabetologist from the city of Mumbai. Lotika ma'am, hello, welcome to today's webinar on women health, Shakti, triumph of health over diabetes. And this panel today is on how women and NCDs, how we are different. That's what Puri ma'am has shown. But what more can we do? My first question is to Archana ma'am. Archana ma'am, if I may start by talking about, type 1 diabetes, which is seldom talked across various different life stages. When a girl has type 1 diabetes, what are some major, situations that she is in with different backgrounds as well, privileged as well as non-privileged? And how should we as healthcare professionals be, addressing those?
Thank you, Dhruvi. First of all, it's a pleasure to be here, and kudos for arranging this wonderful forum. A happy Women's Day to everyone here. Yes, coming to type 1 diabetes, it is different. We know biologically, physiologically, the difference definitely exists. And as you mentioned, as Purvi mentioned, the social determinants of health also make a huge difference. So just going by it from a very simple biological action, the first question when a girl is diagnosed with type 1 diabetes, even if she's 3 years old or 8 years old or whatever age she comes in, the first question parents ask is, will she be able to get married and have a baby? So somewhere our society prioritizes childbearing as a goal of being a woman rather than, will this girl grow well? Will she attain her height? Will she study better, become something? All those things are not prioritized. So, and this I am very sad to say is across socioeconomic culture. So this is not about low resource setting. This is not about somebody who's uneducated. I see this across. There are some enlightened families, and they are there in all kinds. So it's that aspect. But medically, we have to be very careful, because when we get children in a pubertal age, and attaining puberty in type 1 diabetes almost is like a goal. So when my child attains, when her Tanner staging is going well, and when her menses actually occurs, menarche happens, I mean, we feel so thrilled. I mean, we celebrate it, and maybe more than the family celebrates it. So medically speaking, we should have a growth chart. We should be aware for if a girl from 9 years of age, look at the stagings. Even if we are not, I'm not an endocrinologist, I'm not a ped endocrinologist. I work in a support group. Yet we trained ourselves with the Tanner staging, with the growth charts, so that we are seeing that they are growing properly. So, I mean, there's lots more, but this is just the initial bit that I wanted to share.
Thank you, ma'am. From type 1 diabetes, we understand type 1 as such is very difficult to manage. But then I want to shift the focus to the adult. We have Dr. Shalini Jaggi, ma'am, from the city of Delhi. She's the chair RSSBI Delhi chapter and the president-elect of DIPSI. Ma'am, there is a lot of interconnection between various different NCDs, be it diabetes, be it hypertension, be it dyslipidemia, and Purvi ma'am showed us so many statistics and evidence as to how women are different. Ma'am, how do women face a challenge in getting themselves screened, getting themselves diagnosed? Is it delayed? Is it different for women in a real world setting, except for what we have the papers, our cities talking about?
I would like to continue with what Dr. Archana said. She talked in context of type 1. Let me tell you, most often, even, I sit in New Delhi in a tertiary care center. But most often, you will see women being irregular in their follow-ups, women hardly going for the routine checkups as per protocol, women skipping their medications because they're too busy looking after the husband, ensuring he takes his tablets on time, looking after the health of children, sending them to school or to college or to their work or whatever. So I think most important is for a woman to understand that she needs to prioritize her health first, because talking about NCDs and the burden of NCDs, we say diabetes is more in women, more dangerous in women, it kills most of them. But basic diabetes management, visiting a doctor, doing your routine tests, taking your medications on time, eating on time, these are some things that women do not prioritize. And when I see this happening in a city like Delhi, I wonder what happens in Class B, Class C cities and rural India, where a woman has I think multiple roles to play. Similarly, even if it is a homemaker or a working woman, balancing work and life again is a huge challenge in itself. So there, putting health at center stage is something that really needs to be ingrained and taught, and women need to be sensitized to put themselves first. That prioritizing your health, prioritizing your physical as well as mental health is very, very important. And this is a challenge that has actually resulted in, one of the main contributors. I'm not even talking about all the physiological and the anatomical and all the other contributors to this rising burden of NCDs in women. But I think just looking after yourself, going out for a walk, exercising in whatever constraints you may have, eating on time, those small things probably can help us. So I think this is very important.
But ma'am, Archana ma'am, Shalini ma'am, both of you said, but this is such a centuries old conditioning, don't you think? I, again, moving a little bit off the topic, I feel we are conditioned to take care of others before we take care of ourselves, and it is true for the panel present here. And I remember myself telling it to each and every one of you sitting on this panel that please take care of yourself first. If this is our own situation, I can't even go out and be talking about what would be the situation of others. Purvi ma'am, I come to you with my next question with regards to CVD. Ma'am, women present with some atypical symptoms and signs when it comes to cardiovascular status, how can we improve the early detection and personalized intervention for strategizing how we can reduce the CVD mortality in women, ma'am?
Excellent question, Dhruvi, because most people keep forgetting that there are more women dying of cardiovascular disease than breast cancer. So, when you hear of things like the breast cancer or any other cancer or anything else, you get a little more alert about, what is required for your health. But you completely, I mean, most women with diabetes, even post-menopause, they have no clue. There is no awareness in them. And I think I blame ourselves only for not regularly talking to them about their increased risk post menopause also. And even before menopause, the presence of diabetes itself is obliterating that, entire protection from estrogen. Their risk is as good as a man's even before menopause. But I think most women are not aware of that at all. And hence they do not want to, they are so readily supportive of their husbands going through an ECG or a 2D echo or even a coronary angiography, whether it's the conventional one or the CT one. But they are so hesitant in getting themselves tested for or screened for any of these. But I think that awareness and that emphasis has to be, and they feel like, "Nahin, everything is okay. I'm doing fine." You may be doing fine, symptom wise, but you may not actually be fine. And that fine line we need to cross with more and more awareness that, you are the one who's going to probably get the next heart attack in your family if you don't prepare well for it. So I think that awareness is really important. And then again, maybe Women's Day and other such days should be used as even by laboratories and other screening facilities. They should be used to, don't give a sale at Westside, but give a sale at one of the radiological centers. Maybe more women will go and get screened. So I feel that we have to incentivize in some way or have discounts or something to encourage that screening. And that will also further, go into that cycle where they feel that, okay, we need to do this.
Thank you.
If I may just jut in for a moment, Dhruvi.
Yes, ma'am. Yes, ma'am.
The other angle, Purvi talked about this very important angle wherein women themselves are not really taking their cardiovascular health seriously and screening for it. The other angle is, even if a woman is sometimes having atypical symptoms, the family, the caregivers, or even the physicians pushing it under the carpet as anxiety. She's too stressed out. She takes everything very seriously. I've had this lady about last week only sitting in front of me with her son who comes and says that, I have difficulty sleeping. If I sleep, I feel breathless. I just have to get up. So the moment I sent her for an echo, and then I asked her, do your feet swell up? Do you get shortness of breath very frequently? And she was like, yes, I get a lot of ghabrahat. So the son has been saying that she's been complaining of this for the last 10, 15 days. But, we're having business problems and she takes too much stress and that's the end of it. I sent her for an echo. I told them it could be something and it turned out to be a heart failure, acute frank heart failure. So I think simply attributing ghabrahat, anxiety to stress, because, she takes all the stress on herself and that's why she's having these atypical symptoms. I think we really need to be very, very sensitive to all this, sensitize not only the woman, but the entire family. And as doctors, I think we need to also be very proactive in taking some mild symptoms very, very seriously and not just attributing this to anxiety and giving her, anti-anxiety drugs.
Another classical symptom, these are the atypical symptoms related to coronary artery disease. But I think one thing that we often miss in women and is highly prevalent is the heart failure fatigue. And most women in that age group will just come with, just thakawat hai. So we attribute it to, dysglycemia, we attribute it to just lack of protein, we attribute it to many other scientific things except for heart failure, and we don't screen for that. that's also very important, because again, even with preserved ejection fraction, I think we have to train ourselves to look at many more things except just the LVEF, number. So I think that like women just don't associate themselves with that heart failure or other things. So I think again,
Yeah.
we need to get
Somehow
that.
the concept is always that the man is the one who can have a heart attack. The women cannot have a heart attack. That's always the thought that, it could be acidity, it could be today I've eaten something, it has not agreed with me, all these kind of symptoms. And usually they tend to take some home remedy, and, they do not even reach a doctor or any medical practice.
My take is that it's okay if it's not okay, but we can understand if the society does it. But if a clinician does it,
Yes.
how is that okay? So
True.
for me,
Yes.
what is not forgivable is a clinician, male or female,
Yes.
not taking it
Very
seriously.
true.
And this we see every day. I totally agree with what everyone has said, that women's serious, I mean, every other day I get one patient, and this is so frequent, who I'm getting a cardiac workup done because it has been just told that you are anxious, you are too stressed out, and that's why you have these vague symptoms. The clinicians are not taking it seriously. That's my worry.
Yeah, that's a wonderful discussion for cardiovascular diseases. How about CKD? And I'm going to direct that question first to Dr. Lautika ma'am, and then every one of us can chip into that. Lautika ma'am, how do we strategize for better screening, better diagnosing in women with diabetes?
So, of course, first of all, Dhruvi, thanks a lot for creating this platform for us to share our opinion, to celebrate ourselves as well as the other women on this special occasion, and for being able to highlight the topic that women face day to day. Like you said, that, kidney disease is again a silent kind of killer, which is not usually detected. And most of the times, most women do not even reach the doctor, like how I said earlier, for any symptoms. However, what we can strategize is that every time they visit a clinician, if even the blood pressure is taken, to see whether their normal blood pressure, to explain to them what is normal, to see to it that they have to remember to have it checked on a regular basis. That itself can prevent like a primary prevention for them. Of course, if they are diabetic, their HbA1c needs to be well controlled. Their lipid levels needs to be well controlled. Also, if a creatinine could be checked once a year, or a renal, function test could be done once a year. Microalbuminuria also, if it could be done once a year. These are things which are standard practices, but unfortunately, they are never followed, because most people think that, they visit a doctor only if it's something serious, and that serious is usually a cough, cold, fever, or something like that. And they don't worry about all these other chronic ailments which they are having.
Thank you. It is important that I'll give it to the audience right now that
Yes.
all our stalwarts, all our panelists are emphasizing on good screening, good education, good awareness and advocacy for screening all women with diabetes for complication, be it cardiovascular or be it chronic kidney disease. I've come to Dr. Manisha to talk about the younger females in the reproductive stage of their lives who come with, complaints of PCOS. How addressing PCOS early on, or how addressing insulin resistance early on, can help mitigate, or eliminate the later complications of metabolic syndrome in the later stages of life for a woman.
Thank you, Dhruvi, for inviting me to this Shakti platform. And I wish all the beautiful ladies present here happy Women's Day. Coming to I was just thinking about, we do not respect ourselves. So women should have a respect for herself, and then all the problems will be resolved. Whatsoever the men are saying, I do empower female who come to me, and when they have been dominated by their husband, I really get angry with them. No, stand for yourself. This is high time. Come on. So, and coming to your question, Dhruvi, PCOS is, we all know this, like what happens first is the insulin resistance, and that continues with a lot of like obesity, and then you have cardiovascular diseases, and when they enter into their reproductive age group. So before entering into that, they should focus on their diet, lifestyle changes, and what best they can do with their medication in terms of getting into their tests done, especially their genetic biomarkers in terms of AMH or adiponectin, that needs to be addressed well. They should take more of their health seriously in terms of their digital well-being, use more of AI, ask AI, and AI will answer everything, all the queries, and use wearable devices. And that I tell them, download this Google Fit, make sure you are active for like 10,000 steps a day, and somehow you just fulfill the target. If you're not able to walk in the morning, like divide it in like 10 minutes or so, because women are like, we are too occupied with the work, and their work is never over. Dr. Rishi always says one thing: agar raat na ho to kaam khatam na ho. So that's applicable to all the women, including us. We as a physician, we are talking a lot, and once we go back to our home, we are flooded with work. So coming back to my question is like, addressing of all the situations, all the circumstances plays a major role coming to in their reproductive life. Preconception counseling is the must, giving them a good quality of care, mental health support, and medications in terms of like few women would do better with metformin, where other might need GLP-1 analogs or SGLT2 inhibitors. Their thyroid or chronic fatigue, pain needs proper addressing in terms of other autoimmune factors. So, and there's certain medicine like orlistat can be added. There needs to be motivated, well-being, mental health, good support from the clinician, and complete integrated approach needs to be provided to every woman, whoever is visiting to your clinic.
Thank you, Dr. Manisha. Amazingly put. That reminds me to quickly ask a question to Archana ma'am about a holistic approach for psychological as well as, some preconceptional reproductive, hints that need to be taught to the healthcare physicians so that they can treat the women well.
I think that's absolutely important. And our preconception counseling starts even before they get married. So from day one, I mean, when they start looking for a guy, because they have to start a contraceptive. If they're on a pill, it has to be at least a month before. And, socially, they're not okay. They're asking their spouse, and then they come back pregnant in 1 or 2 months of marriage. So few aspects. First aspect is definitely if we tell them the baby, I'm just saying tricks for the doctor, like baby is not going to be healthy because mother's health sadly may not be a priority. But if we say the baby is not going to be okay unless the blood sugar levels are in this range, if food is given that often, monitoring is that often, it works. I have seen in the most rural, all the girls who are not well controlled get well controlled during pregnancy. So pregnancy is a great time, great motivator to actually get them into the best of control, because the most negligent mother, father, in-laws, husband, everyone wants a healthy baby. So we really have to sell that concept of having a very healthy baby. And that is a time to teach them carb counting, dose adjustments, multiple monitoring. And when they can do it for 9 months, it sort of gets into a habit and they're able to carry it forward. Having said that, there are a lot of dilemmas because a lot of unplanned pregnancies do happen. And what observation that we have had is in type 1 diabetes, it's not as bad an outcome as with type 2 diabetes. So we have yet not discontinued or advised or even said that to a person who comes with, say, with a HbA1c of 9, because the moment you still get them into a tighter control immediately, and in type 1, you can get a control right away. Like it takes 24 hours to get them into control. And when you have them there, the outcomes have all been good. So preconception counseling has to start from day one. Tight control for the outcome of baby is what makes more of a difference than the mother. Use that opportunity to create self-care learning. The whole structured diabetes education is at its peak when a woman wants to conceive. And I have found that people are very compliant. It's very, very rare And if they do not, then please look for a mental health issue or a learning disability. The only, I mean, there has to be something very seriously wrong with the to-be mother or the family for them not to want to be healthy when they're pregnant. So there we really need professional look rather than telling them, okay, you're not doing this right. You can't blame them. Something else is wrong. Look for it.
Well, point well taken. Thank you, ma'am. Thank you. Lautika ma'am,
Yes.
there are some taboo topics like sexual health which are not regularly discussed in our OPD. What steps can be taken, ma'am, to integrate the sexual health assessment for women in our diabetes OPDs?
So the first thing is that you have to create an environment wherein they are comfortable talking. And the other thing is that we have to ask sexual history. Because if we don't ask, they will not tell. And we have to create that kind of rapport with the patient for them to be able to comfortably discuss this. Because otherwise, what happens is usually it's the husband who says that, okay, she is saying something, but that's very rare for that to happen. But I think if we give a space to a woman to probably open up and discuss, and it is more like an endothelial dysfunction, like how we see all other way talking about heart, kidneys, eyes, feet, everything else. So why don't we talk about this? And then once we are able to get some conversation, then probably an examination needs to be done, which, probably by a gynecologist or something like that. And thereafter, if there is any physical issue that can be treated, if there is any hormonal issue that can be treated, and again, if there is some issue with mental health, that also can be evaluated. So I think that is at least a good place that we must ask, and that's how we can, get something moving on the topic.
So starting a conversation is the most important thing. Archana ma'am wants to add.
I just wanted to share. So what we did in our clinic and which worked for us because people were not talking, especially in a semi-urban environment. One, we put a poster outside in the local language for men as well as women. And then we did a copy of that poster with a checklist of problems, which I keep on my table, and it's also with my educator. So sometimes they will just, we give it to them and they will just say, wo 6 number wala problem hai. Because they can't even say the word. They're so being conditioned that way. They say that 6 wala. So okay. So that way the conversation starts. You have to give them an easy way in.
True. That's amazing.
So one of my last questions of the panel today is to Dr. Manisha. How about the other autoimmune disorders and their correlation with the diabetes care? What should we as doctors be doing for these women?
Like other autoimmune disorder, we often come across, especially in the women, when they keep complaining of this chronic pain, fatigue, tiredness, and that's like never ending kind of. So further test needs to be done for that is rheumatoid arthritis or SLE or Hashimoto thyroiditis. So that needs to be ruled out, especially doing this antibodies test. And you need to make them aware that this is a chronic treatment will be on, and they need to be on medicine throughout. So that's one thing which we usually do in our clinic, especially if it's a type 1, then other autoimmune factors like thyroid or celiac, we usually do it on the yearly basis for our patients. And definitely when the patient is on these chronic disorders, they have this notion that things will become all right. Once the cure is done, they get relieved and nothing like the medicine will be stopped. So definitely a multidisciplinary approach is needed. And it's a combination of like all rheumatologists needs to intervene if it's a arthritis thing, or endocrinologist, cardiologist, or everybody should come together and play their role effectively.
Well, that's great. We have one question for our panelists from the audiences as well about diabetes distress. Purvi ma'am, Shalini ma'am, either one of you, do you want to take it up? How should we be assessing diabetes distress in our routine OPD?
So again, diabetes distress is very common and yet not, acknowledged very often. So one needs to have a lot of high amount of empathy. And even if, say, for example, the patient requires insulin and in your best opinion should get onto insulin at the earliest, and the patient may have severe needle phobia or, injection phobia, talk to the patient. Talk, give, understand, just spend that time with the patient, make them comfortable, tell them you're going to do exactly what they want and not what you want to do for them. And then, rationalize with them as much as possible. Have their family members also to support them, because that's also going to be, again, an important factor. And try to use options which are, say once daily, once weekly, whatever, in whatever way we can simplify their medication regimen, or whatever they are feeling most distressed about, will be very, very helpful. So this is just in short, but it requires a lot of, creation of that rapport. And that's where a team also helps, because you as a physician or clinician may not have that much time to spend with that person to alleviate the distress, but your team members also can be supportive and, calm them down, just agree with what they are saying, and then get them to see your point of view. I think that initial fear is that, we are going to impose everything that we think is right for them, rather than having them, being an equal partner in deciding what they need to do.
Well, thank you, ma'am. That's
That
interesting.
patient-centric approach is what will help address this distress.
Shalini ma'am, just one more question that popped up is postpartum hyperglycemia. Women stop whatever intervention was done with them post-delivery. What is the postpartum care, and what is the interval at which we should be, screening them for diabetes after their delivery? Ma'am, your camera's off.
I know there's some issue with my camera. Okay, so I think it's very important that even when they are pregnant, you talk about the importance of postpartum follow-up, because pregnancy is such a low-hanging fruit. They are very receptive to everything that you are telling them. So I think this is where it becomes very important to tell them, especially somebody with gestational diabetes. We know post-delivery for the next 3 days, as long as they are with you in the hospital, checking is very important, checking their glucose levels. And then you can always ask them to do screening, a GTT, in the next 6 to 12 weeks post-delivery. Am I audible?
Yes, ma'am, you are.
Yeah, okay. So 6 to 12 weeks post-delivery, a GTT should definitely be done. And then the need for an annual GTT is very important. NICE guidelines do tell you about the HbA1c also, but simply relying on an HbA1c as a measure of pre-diabetes or progression to diabetes is not really indicated. A GTT and then routine losing all the gestational weight is very important. Planning for the next pregnancy starts on delivery of the first pregnancy. So, stress about the importance of preconception control. Tell them about the recurrence of GDM in the subsequent pregnancy. If they do not progress to type 2 diabetes, many a times between the two pregnancies only you will see them turning into diabetes, So tell them that your risk for turning into diabetes is still very high, and therefore lifestyle, losing gestational weight gain, exercise, eating right are all very important, and screening. So this becomes very important. So I think your preconception counseling starts even post delivery, and then it is an endless process. Even once they've completed the family, importance of maintaining glucose levels, preventing diabetes, or if they do get diabetes, taking adequate treatment and optimizing glycemia, screening for complications. I think looking after their health has to be an ongoing process, which should not end only with pregnancy or in the immediate postpartum period. It has to be an ongoing process.
Well, thank you, ma'am. With respect to time, now may I request all my panelists today to give a one-liner wrap-up answer as a message to all the physicians taking care of women as a whole. Can I start with Archana, ma'am?
Yes. So my message would be to reduce diabetes distress, to make people more compliant, would be if you could employ as many people living with diabetes in your team. That's a great equalizer, normalizer. For type 1, it works magically, but it works very well for type 2 as well. So that empathy, that whole energy that comes in makes a huge difference. So that's one small tip. If you could, that would help.
Thank you, ma'am. Latika, ma'am.
So difficult to summarize everything in one line, but I think we need to look after ourselves. So check more often, and there should be probably a checklist which should be followed, and yeah, that would probably reduce the distress. And once you have some clear goals, it makes it easier.
Thank you. Dr. Manisha?
Just take good care of yourself. You are precious and the most lovable thing on earth. Have some respect for yourself, and you deserve the best, whatever is available. So that's my my take for myself also.
Kudos. Agreed. Shalini ma'am?
I think for a woman, you as doctors, we have to move beyond just the bikini medicine. It's not only the breast health and the reproductive health for a woman, which is different from a man. I think look at the woman as a whole, her entire physical health, right from when she's a little girl to attaining puberty to becoming in the reproductive age group, post-menopausal. So I think the entire life circle, the life journey of a woman is very different. And I think sensitizing yourself and her and the family to the differing needs as per her life cycle, and practicing medicine which is in sync with that life cycle and her needs, both physically, mentally, emotionally, is very, very important.
Thank you. Thank you, Shalini ma'am. Purvi ma'am?
So, a very brief message to all women, whether it's healthcare providers or patients or people living with diabetes, save yourself because no one else is going to. That's my, takeaway. So you do what to get the correct information about what you have, what precautions you need to take, what medications you need to take, how you need to manage it, but take that ownership and the responsibility. You shouldn't, your health is your responsibility, not somebody else's.
Wonderful, wonderful messages from all our panelists. I thank you all again for spending your valuable time. There's a lot to be done, and we are going to keep continuing to do a lot for women across the globe, across their different age categories and life stages. Thank you so much. Can I request the RX team to put up the one slide CV for Dr. Nandita ma'am? Thank you again to all the beautiful panelists who are brilliant minds, before anything else.
Thank you.
Thank you so much, Dhruvi.
Thank you.
Thank you.
So, welcome Dr. Nandita ma'am. She's the director and diabetologist for A. Ramchandran Center of Diabetology and Research at the city of Chennai, Tamil Nadu. Ma'am has been doing a lot of research, academic as well as clinical work. She's got a lot of awards and accolades to her name. And without keeping you all away from her, I'm going to request Nandita ma'am to take up her talk today.
Thank you, Dhruvi. Hi, everyone. So happy to be here this afternoon on the special occasion of Women's Day. And thanks to Dhruvi and Ami for inviting me and making me part of this very special program. Can I very quickly just share? Yeah, okay, perfect. So what I'm going to be discussing over the next couple of minutes is the importance of cardiovascular health, especially in women with diabetes. And I'm going to start off with a sort of a clinical scenario. It was very nice to listen in on the panel discussion from our my close friends and experts in the field. But in that context, there was a lot of discussion about case scenarios and importance of women's health during pregnancies and so on. But so I thought it's always best, because at the end of it, we're all clinicians, and it's always better to set the context with a case study. So this is a clinical scenario in which a 45, based on a true incident which has actually happened, where a 45-year-old lady who was the wife of a carpenter, mother of 3, living in the village, was a known living with type 2 diabetes since 13 years on medication. And this lady developed pain in her back and shoulders since 2 days. She then visits the clinic, which is close by, and which is the nearby clinic in her village, in her town. And the doctor sees her and prescribes just some painkillers and sends her back home. By day 4, the pain still persists. and then she develops vomiting, returns back to the clinic, when then the doctor decides to take an ECG. And that by then the ECG shows that there is already an evolved inferior wall MI. And this is not just a cooked up hypothetical story, but this is actually, like I said earlier, this is based on a true incident that actually took place. The fact that this lady actually did seek medical advice, and yet, no one's to blame here, but yet it was sort of dismissed. And the reason that I think maybe there was a bit of gender bias there. Maybe if the same thing was a male, we would have probably taken it a little more seriously. Somehow, when it is a premenopausal woman, although she's diabetic, somehow it is always dismissed that, maybe it can't be a cardiac. So if an ECG was probably taken in the first visit to the clinic, a major catastrophe could have probably been avoided. And here you, of course, luckily the lady then made it because an angio was done, and she is now okay. But what the damage that has actually been done is already done, because she does have some residual cardiac failure and low ejection fraction that she's living with. So with that being set as the context, we all know this is prevalence data to show us that we know that there are exploding numbers of type 2 diabetes in our part of the world. And this is data that we have been looking at right from 1980s to the 2000s. And what has been a mere single digit that my father published in the 1980s has now sort of exploded to double digits from a mere 5% to around 25-30%. 22% is the prevalence that we have in 2016 in the urban, and more so in the rural areas. As you can see, a mere 2% has now gone up to around 14% in the year 2016. Now, we know that what we looked at in the previous slide is that there is, in fact, a growth and a rapid increase or rise in the prevalence of type 2 diabetes. But what we're looking at over here is the region-wise percentage of increase in the prevalence of type 2 diabetes. And what I'd like to bring your attention to is everywhere, of course, globally, you see that the percentage of growth of prevalence of growth rate is higher in women than in men. And when we look at South Asian population, we're not far behind. Again, women, the percentage of growth rate of type 2 diabetes prevalence is faster or higher as compared to that of men. Furthermore, this is data in which the similar sort of study that we looked at, that I showed you from the previous data. The previous data was actually prevalence of type 2 diabetes. But in the same population, we also wanted to look at prevalence of not just type 2 diabetes, but cardiovascular data. But before we move on to that, what I'm going to show you is a change in the prevalence of type 2 diabetes in both the rural and the urban areas in our own India. And this is in southern India, in Tamil Nadu. So we're comparing data between city, town, and village. So looking at urban as well as rural areas. And what you're looking at right on top is the total prevalence, including men and women. The total prevalence has, in fact, significantly increased. And this is over a period of 10 years, a decade later, when we went back to the same areas that we had studied in 2006, we went back 10 years later to look at the prevalence in 2016 and found that, in fact, there is a significant rise in the prevalence of type 2 diabetes in both the urban and the rural areas in both the genders. Now, when we tease this out and look at male versus female, yes, there is a rise in male, but in females, there is in women a significant rise, not just in the urban, but also in the rural areas. But in men, it is more so in the rural areas. So that's the box that what I'm circling over here is that there is a significant more worrisome increase in women as compared to men, and more so, not just in the urban, but also in the rural areas. Now, what is even more alarming, here we're looking at the prevalence of pre-diabetes, and we find that, again, there is a significant rise in both the urban and rural areas, the total prevalence, including men and women. But Furthermore, there is a significant rise in the prevalence of prediabetes in women as compared to men. And look at the numbers we're looking at here. When we look at the city, it is 11%, which has doubled to 22% in the city. And in the rural areas, it's even worse. It is from 8% to almost 18%, from a mere 5% that it was in the city of Kanchipuram, in the town of Kanchipuram, to 23% in 2016. So a significant explosion or a large a high rise in the prevalence of not just diabetes, but also pre-diabetes in women as compared to men. And why is this important? We know that pre-diabetes is also like a ticking time bomb where people are waiting to convert to type 2 diabetes, and pre-diabetes itself is a high cardiovascular risk state. Furthermore, now we're looking at data in terms of trend in cardiovascular risk factors among women. And here again, we find that there is a significant rise in cardiovascular risk factors as well, including dyslipidemia in the rural areas, hypertension in the urban areas, and increased overall obesity, that is generalized obesity in urban as well as rural areas, and a significant rise in waist circumference. And this is relevant. Just a couple of days ago, we were all talking about the importance of lifestyle modification. We were all talking about the importance of on World Obesity Day, which was just 2 days ago. But we're looking at rise in prevalence of obesities, especially abdominal obesity and generalized obesity as well among women in our part of the world. But in spite of all this data that I showed you, what I showed you was a rise in the prevalence of type 2, rise in the prevalence of obesity, rise in prevalence of dyslipidemia, hypertension, cardiovascular risk factors among our own women in southern India. What we're looking at over here is again Asian data that is showing us that sadly, women are not achieving targets. And we're looking at the percentage of women that are achieving the target LDL or the target blood pressure and target HbA1c, and we find that the blood pressure of less than 130 by 80 and the overall LDL percentage, only 50% of our 40% of our women compared to 50%. So we're comparing both men and women. Men are on the middle graph and the women on the extreme right, and we find that 50% of men achieve target LDL compared to 40% of women. 70% of men achieve their target blood pressure versus 66%. A target HbA1c, LDL and blood pressure reduction is achieved in about 30% of men as compared to 20% in women. So sadly, women are faring lesser or are achieving lower targets or lesser targets as compared to our male population. Now, that being said, now, is there a higher cardiovascular risk in women versus men? This is a meta-analysis to show us among 23 studies in a large number of population in which they've shown that, yes, indeed, there is a higher risk of all-cause mortality, 93% higher all-cause mortality in women with DM versus women without DM, 74% in the same population in men versus DM without DM. And in the same pool data, women versus men, the all-cause mortality, when we compare women versus men, there's a 13% greater all-cause mortality in women with diabetes versus men without diabetes. Furthermore, the 2-year survival rate post-MI, after the first myocardial infarction, the percentage or the probability of survival is lower. You're looking at the two graphs in which the red is women and the blue is men. And the probability of 2 years probability of survival post-MI, first MI, in people with type 2 diabetes is lower in women as compared to men. In other words, cardiovascular disease risk is higher in women. And number two, it is also more dangerous in women. Now, why is this so? Are the risk factors different? And that's what we're going to be looking at in the next couple of slides. And yes, indeed, there are some gender differences. We know that there are diversities in culture, in lifestyle, in overall socioeconomic status, more importantly, in biology. Biological difference is the fact that women go through various changes throughout their life or in their life cycle. So as a result, at each stage in a woman's life, she is going through changes in her entire biology, in her metabolism and her body composition, her energy balance, her regulation of the hormones. Everything is changing right through her life cycle. This itself increases risk and is the sort of sets the tone for a different cardiovascular risk factor pattern as compared to that of men. So as a whole, women, yes, do have the traditional risk factors which we're seeing here on the left, which is smoking, type 2 diabetes, overweight or obesity, physical inactivity, poor lifestyle, dyslipidemia, hypertension, all of which are on the rise among women, which I showed you earlier. But beyond that, there are some non-traditional cardiovascular risk factors specific to women, which are gender specific, like preterm deliveries, preeclampsia, gestational diabetes, autoimmune diseases which are higher, and socioeconomic status, central obesity. Women are more prone to mental illnesses like eating disorders, like depression, menstrual irregularities. All these are gender specific risk factors which further contribute to a higher risk of cardiovascular disease. Furthermore, this is a nice paper in which they've actually analyzed the age and the BMI of onset of type 2 diabetes, in which they've actually shown that the threshold age and BMI at which a woman converts to type 2 diabetes is actually higher as compared to men. Now, what does that actually mean? What that actually translates to clinically, or in the clinic, or from more of the clinical context, is the fact that when a woman is actually diagnosed with type 2 diabetes, it is much later than that of a male, right? Their male counterpart. And why is this important is because, as we all know, the moment a person is detected with type 2 diabetes is when, or when they seek medical advice for diabetes, is when treatment is intensified. That is when cardiovascular risk reduction actually is intervened. And that intervention is started much later in women as compared to men, right? Because the threshold age and BMI itself is lower in men. And so men get diagnosed earlier, intervention is earlier. So reduction in cardiovascular risk factors is also intervention being earlier reduces their cardiovascular risk. Whereas in women, it is much later, and so intervention is actually being done later. So the whole concept of hit hard, hit early sort of is negated, and women are already at a disadvantage at diagnosis of type 2 diabetes. So that being said, I think this brings me to my last slide, that there is in fact an increase in the prevalence of not just type 2 diabetes, but also pre-diabetes among, of course, globally and in our part of the world, among both men and women, but more so worrisome, rapid increase growth rates in women as compared to men. Also, we learned that there are differences. There are traditional risk factors that are increasing the cardiovascular risk factors like hypertension, obesity, especially abdominal obesity, and dyslipidemia, which are also on the rise. And I showed you data from our own India, our own women, in which in both, not just the urban, but also in the rural areas, there is a steady rise in these prevalence of cardiovascular risk factors. These risk factors are the traditional risk factors, beyond which there are some gender-specific risk factors, which in turn increase cardiovascular risk in our women. Mortality rates are also higher in women as compared to men. So the 2-year survival rate post-MI is also lower in women compared to men. Last but not the least, women are also diagnosed with, or the diagnosis or the threshold for conversion to type 2 diabetes is later, at a later BMI, at a higher BMI, or at a later age as compared to that of men, as a result of which intervention is also much later, putting them at a disadvantage even at diagnosis of type 2 diabetes. So what I'd like to say in conclusion is that, yes, women with diabetes need more aggressive cardiovascular risk reduction, maybe than men. And do we need gender-specific guidelines is a question I'll leave out there. Thank you.
Thank you so much, Nandita ma'am. Since we are in the same session, I would like to just ask you a question which is posted by one of the audiences. Is education the only way to counter the CVD, complications in women?
I would definitely say education is one of the ways, but probably not the only way. But absolutely, education, I think, goes a long way in enlightening women and also empowering them with the right tools to manage their cardiovascular risk. And I think education should not just be restricted to the woman alone, but also to the entire community, and also to sensitize the men in the family or their support system, because that is also equally important, because many women are dependent on their family members to even sort of obtain medical advice. So education should not be, sort of restricted to, again, just the woman alone, but also to the family members. And yes, patient education does go a long way, beyond which, of course, medical management and treatment also helps in reducing cardiovascular risk.
Well, amazingly put. Thank you, ma'am. I think we'll still keep you on here, and we'll
course.
have some further discussions. Thank you, ma'am.
Sure.
I
Thank
take
you.
this great opportunity then to take the webinar forward and introduce the host of today's webinar, Dr. Ami Sanghvi, clinician, academician from the city of Mumbai. She is a diabetologist at Sanghvi's Eye and Diabetes Care Center. She's been catering to multiple women with diabetes, taking care of not just one generation but multiple generations together. So I just wanted to introduce you, and that is why I stopped you from taking on the panel before you could. So over to you, Ami,
Very
ma'am.
kind of you. So that's very, very kind of you, Dhruvi. Thank you so much. And so I think it's time to now again go for a very interactive panel discussion. And the topic is like, a very good one. We are looking at a precision approach to lifestyle modification for obesity in women. And I invite my esteemed panelists along to join with me. We have Dr. Kavita Gupta, Dr. Neeta Deshpande, and Cheryl Salis joining us for today's panel discussion. And then we invite the other faculties also to remain tuned in. We would like to have their inputs as we go along the panel. Can we have the introduction slides of the panelists, please?
RX team. Do we have somebody from the RX team to help us with the technical thing, please?
RX team?
Neeta ma'am, maybe you can just introduce, and I'm trying to call them.
Yeah. Neeta ma'am is joining in a minute. I think we'll have her here in a minute. So, yeah. So, introducing our panelists for today's panel discussion, we have Cheryl Salis, who is a registered dietitian, certified diabetes educator, insulin pump specialist, founder and director, and a very, very good friend. She nurtures the health solutions in Mumbai. I welcome you, Cheryl. Then we have the next slide, please. Okay, I think we have Kavita ma'am from Nagpur, who is again a very, very well-known personality amongst our circle. We are privileged to have her. She's a diabetes educator, and she runs many programs on social media to educating people about diabetes. And we have Dr. Neeta Deshpande from Belgaum. We are really, really privileged to have you, ma'am, on this panel, along with us, a national faculty across forums, an obesity consultant, and a great orator. So I welcome you all, and the other speakers who are still with us. I welcome you all on this panel. So let's get going. Neeta, ma'am?
Yes.
Yes.
Am I audible?
Very, very good afternoon to you.
Yeah.
So, ma'am, starting with you. So, when we talk about, we're talking about calories, we're talking about calories and precision medicine. So, when we talk about calories, how can we shift from the approach, which is there, the calories in and the calories out, to a more personalized approach for obesity in women? And just to add on, does genetics, microbiome, or hormones have a role to play in determining this obesity across a woman's lifespan?
Right. So thanks for asking that question, Ami, and I thank this entire team for having me on this very beautiful and nice webinar. I'm very happy to be here. So the question that you posed, Ami, is about the calories in and calories out. You often find everyone actually, going on the net, trying to eat something, counting the calories, and then going on the treadmill and saying, I lost 200 calories, I lost 300 calories. That is absolutely erroneous. The reason being that calories in and calories out depend on a lot of personal factors. So a person with a fat percentage of 25 versus a person with a fat percentage of say 40 or 50, they're not going to lose the same calories on the same treadmill for the same amount of time. It depends on their muscle mass and the fat percentage. It also depends on age. It also depends on sex. Women will tend to expend less energy. So simplistic as it may sound, the calories in and calories out, it is never a mathematical equation, because there's a lot of biological factors, metabolic factors that go into this, which will determine how much you expend, and secondly, even what you eat. How you respond to your carbs, how you respond to your fats, and how you respond to your proteins is again very much personalized, dependent upon your age, sex, muscle mass, fat mass, and stress factors, and so many other things. So it is a too simplistic. It is very erroneous. We cannot go based on how many calories you ate and how many calories you have expended. So having said that, you also raise the issue of the different factors that can affect this. You talked about factors such as the microbiome, for example. Well, gut microbiome is a huge determinant and risk factor for obesity. So in general, the more diverse your gut microbes, the less likely you are to have obesity and metabolic diseases. Now, what does this diversity depend upon? The diversity depends upon not eating processed and ultra processed food, not eating very high fatty foods, not eating very calorie dense foods. So all these things, if they are avoided, you are likely to have a diversity of your gut microbes. The other thing is that if you're eating the same thing every day, day in and day out, your diversity becomes less. At extremes of age, the diversity of the gut microbes is less. So if you want to increase the gut diversity, you have to eat different things, and you have to eat healthy things. You have to eat unprocessed food. So this will make your gut microbes much, much better. When it comes to genetics, yes, 20 to 30% of all obesity can be said to have a genetic basis, but over and above that, you have epigenetics and you have the environment. Because here we are talking about the garden variety polygenic inheritance obesity. We are not talking about the single gene defects like leptin deficiency or something like that. So environment plays a huge part, which to a certain extent can overcome genetics. The only issue comes where you have those patients who are doing everything by the book, but not losing weight. These are those people who are metabolically inflexible. It means they can never switch from they can never switch to fat burning. So this can be a genetic issue. So yes, you find that many people in the family have the same weight. They don't lose weight even on a diet. So these are the tough ones where we call them metabolically inflexible. So they have to be dealt with a little differently. And lastly, you asked about the hormones. So hormonal changes occur at two extremes, puberty and adolescence, and they occur at menopause. So at these time points, the hormonal changes are extreme. and hence the fat deposition is also excess. So you really have to take care of these very, very differently. Apart from that, in between, there's a fairly constant interplay of hormones where then environmental factors can kind of take care of it. So the other two extremes you have to deal with differently. So that's why, as you very rightly pointed out, precision medicine is the key. You have to know what is the age, sex, what, especially in women, at what stage of her life she is in. All these are going to determine the success or failure of your efforts.
And even maybe look at the families, whether there has
Absolutely.
been weight loss. So I think it's very beautifully put, ma'am, that every person is different. So we have to look at every individual when we are looking at weight loss. So beautifully put. So when we talk about this precision medicine, let's dive a little deeply. So I'm coming to Kavita ma'am now. So ma'am, now we will try to go through every stage of a woman's life, and because as ma'am too mentioned that every stage is important, there are hormone interplays at every stage of our life. So Kavita ma'am, when we talk about birth and infancy, do you think that the impact of maternal nutrition and gestational weight gain during pregnancy would shape the obesity risk in the female infants? And also along with that, would you highlight the impact of breastfeeding versus formula feeding in infancy as a foundation for obesity prevention?
Thank you, Dr. Rami, and thank you, the entire beautiful women out here. Wishing you a very happy International Women's Day.
Thank you.
So that was a very important question, actually, and thank you for having me over here on this important panel. So, when we are talking about maternal nutrition, I think maternal nutrition is very, very important because your two generations are at risk. It is a mother and it is also the offspring. So basically, it is the intrauterine metabolic environment, which is very, very important because here is where, we can also avoid the epigenetic changes in the offspring. So that is why maternal nutrition should be given importance from the day one. I wish I could start giving this nutrition importance to the adolescent girls because they are the future mothers. So that is why we have to start way before, way beyond
Ami ma'am, you're on mute.
Some signals.
Yeah, I think, yeah, she's back.
Sorry, Kavita ma'am.
Yes.
Yeah.
So basically, in pregnancy, it is the intrauterine metabolic flow which has a high impact from the day of conception to the phase of organogenesis to the delivery. So basically, we need to keep on counseling, the pregnant woman or even the young woman about having a healthy diet. So now coming to the gestational weight gain, so if the pre-pregnancy BMI is normal, if the total weight, if the pre-pregnancy BMI is normal, the total weight gain during pregnancy should be around 10 to 12 kgs, we know. But if the or
I think, ma'am.
Yeah, am I audible?
Now you're audible, ma'am. Now you're audible. We lost you in between for a minute.
Okay.
Yeah.
Yeah. So actually, if all the overweight and the obese women are at higher risk of giving a preterm birth, they have higher risk of C-section, they have higher risk of giving birth to a macrosomic baby. So all these people, all these morbidly obese women are also at higher risk of developing GDM. So whenever we are talking of obese women, they are at higher risk of all these So, yeah, when we're talking about maternal nutrition, we need to
Kavita,
understand that the mother.
Kavita, we are losing you
Yes.
frequently in between.
Yeah, I really don't know because I have actually joined from my phone and I really do not understand.
Okay, now you're
Oh,
audible
let
anyway.
me
Now,
try the last time.
Yeah,
Yeah,
no,
I think
ma'am,
it's
we
fine.
let
can
me
hear
try
you.
this
We can
time.
hear you. We can hear you.
So, the pregnant woman should should be having a very healthy and a well-nourished diet because here she will be transferring all whatever she is eating. So, whether it is your carbs, your proteins, your vitamins to the baby, and that is where they will be getting proper nourishment, and they should be, the baby will be developing, with the proper immune, it will be developing into a proper immune system and all. And if you need to step up on the nutrient dense foods. So rather than having a lot of, rather than eating for two, they have to eat for 1.5, but they have to have nutrient dense food. They have to have protein in every meal, and they need to have a well balanced, nutritious meal, which is comprising of low GI foods, complex carbohydrates, good quality of proteins, good quality of fats and fiber. And the key points when we're talking about breastfeeding, we must know that WHO recommends that there's exclusive breastfeeding for the first 6 months. In fact, the feeding should start within the first 4 hours of the delivery because it is the colostrum which has vital nutrients, which also boosts the child's immunity and the overall development. So, we need to understand that the breastfeeding is very, very important. But here we also need to understand that formula feeds can be high in calories, can be high in proteins. So the bottle-fed babies may lead to weight gain. So and they may be overfed because of the bottle fed. And moreover, the breastfeeding, the breast milk has a composition which prevents overeating. It adapts the baby to self-regulate the feeding and it stops when it is satiated. So that is the difference between the bottle fed and the breastfeeding. And finally, it creates a bond between the mother and the baby. So over and all, always breastfeeding should be yes, accepted than the bottle feeding.
So very well put, ma'am. So I think looking at the adolescent girls, we have to, start kind of educating them so that we have healthier babies. So coming to Cheryl, so now moving to the next stage of a girl's life. So you think that in that childhood period, Cheryl, so how do the cultural norms, so as ma'am said that breastfeeding is important, but there are a lot of cultural norms too, that about the cultural norms, the societal pressures, family habits, and even the screen time have started influencing the childhood weight gain. We are seeing a lot of childhood obesity now. So what do you think would be the correct way to go with these girls, in helping them to prevent childhood obesity?
Thank you so much, Dr. Ami and Dr. Dhruvi, for inviting me. And it's wonderful to be here among all my favorite women, celebrating International Women's Day. And I think such a relevant question that you have asked, because we are definitely seeing a rise in childhood obesity and definitely, PCOS and other conditions because of obesity. And in our clinic, we do see a lot of children, especially girls, coming to us who are, in definitely the overweight and even the obesity target range. And cultural norms, screen time, as well as family habits, they play a very significant role. One is in inculcating the childhood behaviors, which in turn will then result in weight gain and childhood obesity. Now, if you look at India also, we're so diverse as a country and so many different kinds of cultural practices. And typically, like the part of the country that I am from, Maharashtra, we do see a lot of communities. And this is now even in other communities as well, where the dinners are becoming very snacky and they think that it is light dinner. But if you look at the dinner, it is very high in HFSS, the high fat, sugar, salt, a lot of refined carbs, so dinners are typically pani puri, bhel puri, sandwich. Now it's pizza, burgers, enchiladas, there's a whole range. So, our traditional home cooked meals are being replaced. Definitely, even if you look at the snack options, because today sometimes parents both are working, the cook is at home or the maid is at home, and typically what the children are eating is out of packets. So there's again a lot of consumption of HFSS foods, which itself is pro-inflammatory. So that is something that we really have to work towards. One is, again, reinforce, traditional food habits. And again, if they want to eat something like this, which is like snacks, which they typically like, or what they say as one pot meal, we have to maybe educate the parents and give them recipes on how do we make it more healthy. And how as a family all of them need to eat the same food, because typically what we see is that especially if there are 3 generations living in the house, grandparents eat different food, then it's the parents and the children typically, so there's separate food being cooked. So I think it has to be a very family approach when it comes to healthy eating. Again, if you look at certain communities, especially when it comes to a girl child, there's a lot of restrictions in terms of going down to play or participating in sports or being physically active, and then that itself is a biggest impediment in terms of being physically active. So that is another big thing that we are seeing, and we have to look at ways on how do we encourage physical activity. And I think today with our children, I mean, I'm a mother to a teenage son, but I'm seeing that, when we were kids, it was, we used to actually wait for our friends to ring the bell at 5 o'clock and call us down to play, and we would not come up even at 9:30 because we enjoyed playing. Today, kids like playing, but like, playing with their fingers and not really, moving their bodies. Even when they go down to play, they're on their phones. So getting them to be physically active is really a challenge. So that's another big thing that we have to look at. How do we encourage more physical activity? I think, again, it has to be whether it's a school, community, government. Because if you look, I mean, in Mumbai, there's absolutely no place to go down and play. Our buildings also, I mean, there's hardly any space, or outside the roads are dark. So who can go even cycling outside or doing anything? And anything requires to travel to a place, which again, with the traffic may not be. So making, parks or whatever, which is conducive for children for physical activity. Then comes screen time. I think that's a big, big challenge that we are facing. And I think post-COVID, it's become even worse because our children they had no choice but screens, and then they were bored, so it was screen. And now that it's become an addiction, and children are definitely spending more time in front of the screen, and everybody has a mobile phone today. And even if you look at the Lancet report, it clearly shows that Indians are physically inactive. And if you look at even, it is more women who are more physically inactive. And this is definitely a fact. So I think one is definitely, is education, awareness, also creating those facilities. I think we always talk about things, but we don't tell them the solutions. There are lots of challenges. So how do we address them, and how do we make it simple? For example, somebody can't go down to, work out. Can I give them a video or something which at home they can do, inculcating the physical activity aspects? How do I give them recipes which are healthy and tasty? Very important, because I think we're all slaves to our tongue. We like tasty food. And unfortunately, sometimes, healthy food may not really be tasty, and we like salt. So that's another thing. And what I would, think is parents, teachers, everybody has to be a good role model. I always tell the parents, they will not they will not follow your advice. They will follow your footsteps. So if you're not going to be physically active, you can't expect your children to do it. If you're going to be sitting on a couch and watching TV, you can't expect your children, because you have to be good role models. And Neeta ma'am is here, and I'm telling you, I get so inspired seeing her. Even in a conference, she'll go to the gym and, work out. So I don't think any of us has any excuses. We all have lots of challenges that we may talk about, but I think that whole motivation to do it and, drive to do it has to come. And I'm sure that will inspire her own children, because they're seeing it, when it comes to their parents. I think that is something which is very important. And I would just say, what I tell my parents and, children is the 9-5-3-2-1-0. So at least getting 9 hours of sleep when it comes to children, that's important. Then comes five, at least, 5 types of fruits and vegetables. Of course, 2 fruits and maybe 3 vegetables. So making sure vegetable is there in every plate. 3 hours before finishing your dinner. Less than 2 hours of screen time. Very, very important. 1 hour of physical activity compulsory. And this is what the WHO guidelines also suggest, that minimum 1 hour of physical activity and whatever they enjoy doing. Because today even physical activities become another stress. You put them from one class to another, that it becomes another stressful thing. Let them just go down and play, maybe badminton, we used to play kabaddi and so many other things. So let it be free play. And definitely zero sugar sweetened beverages, because today they're just guzzling down these drinks which have a lot of sugar. So that is something. And I think, again, the school has a very important role to play, because the kind of food that is served in school is extremely unhealthy. We all talk about healthy food, healthy things. But if you look at the school menus, especially today when we're looking at our elite schools, the kind of food that is there is so atherogenic and pro-inflammatory. So I think, again, making changes right from there is so important, and right from birth. I think that's the most important thing. And I think sometimes parents don't even realize that their children are overweight. They come to us only, like today we do get referrals, but it's only when they go to their pediatrician and the pediatrician will tell them that your child is overweight. Otherwise, they think that their child is healthy because, we love plump children. So that's another thing that I think we have to bust that myth that, plump doesn't mean healthy. Active, is healthy. So I think these are things that we would like to address.
So well put, Cheryl. That solutions is what we are looking at. So quickly moving on to the next stage about puberty and adolescence, ma'am. So when we talk about childhood obesity, somewhere it's going to be shown in the puberty too. And then we have this hormones which play an effect on the distribution of fat. And again, a very, very critical issue and emotional issue which comes here is body image, because those are the concerns, emotional impact it has. So being an HCP, how do we address these issues, ma'am? Neeta, ma'am.
Yeah, so the first thing that you need to understand is that adolescence and puberty, according to me, is a roller coaster ride for that person. Completely. How you land, whether you have a soft landing or a hard landing, it all depends upon what happens during that roller coaster ride. The reason I'm saying this is that I don't think in any other stage of life for anybody is there so much of a change in behavior, so much of a change in hormones, and so much of a change in physiology. So all of these three together make it a very, very stressful condition for that person. And in all of that, because of these physiological and biological changes, a girl may put on, especially girls may put on anywhere between 8 to 14 kilos. And that is something that a girl may not be able to understand and come to terms with. And that there in the genesis of a bad body image starts right there. So as an HCP, the first thing we need to do is explain this to the parents and to the girl that this is likely to happen. So pre-adolescent, pre-puberty, this conversation has to take place. Number one, probably at the level of the pediatrician. Second thing is we need to give them tools to mitigate some of these effects in advance, because as we all know, an obese adolescent is most likely to turn into an obese adult, and it's a vicious cycle. So the physiological changes that can happen are that, number one, the most important is the body composition changes. So because that is under the influence of the hormones, the sex hormones. So because the body composition changes, both in terms of quantity and in terms of distribution. So you are going to have increased fat cells, and you're going to have a lot of them in the hip area and on the breasts, obviously. So all of this is going to change the body shape. So this is something that a girl may not be able to come to terms with. They start looking so different. So this can lead to behavioral changes such as they become excessively shy, they can be reclusive, they can withdraw, and then it turns into a vicious cycle of depression, overeating, and more obesity. So that is one aspect of it. Or they can become excessively aggressive, and this is also the time, because of that aggression and tumultuous kind of a psychological setup, they can go into addictions like smoking, alcoholism, drugs, etc. So this is that time. So all these issues need to be taken together when you're thinking of obesity, because obesity doesn't come in alone when puberty sets in. It brings with it all of these other things as well. And because of this body composition change, insulin sensitivity goes down. And because insulin sensitivity goes down, if that girl also has genetic influences of diabetes, hypertension, cardiac disease in the family, then it is surely going to lead to obesity. So as an HCP, we need to spread the word around that this is what can happen. We also need to give tools to mitigate this by a better lifestyle, more physical activity, maybe strength training. So all these things have to be emphasized more and more at this stage in a girl's life, and the necessary support has to be given and sought from the family and the teachers as well. For example, the teachers play a big role if the body image is not good. If a girl is being excessively shy or aggressive, then the teachers are the first to notice this. And they need to bring this to the notice of the parents that this is what is happening. So you can actually preempt or avoid major body image issues at least by doing counseling at the right time for these people. And then, of course, you have to treat all this. If the weight gain is excessive, then you have to emphasize on the healthy eating, no smoking, no alcohol, and a lot of exercise. So this is how it is.
I think, ma'am, very well touched upon. So importance is, I think, hand holding at that phase of life
Yes.
from the family will really, take them a long way.
Yes.
So now that our adolescent girl has grown up well, and now she comes in the fertile years of her life. So, Kavita ma'am, we would like to know the impact of obesity on the reproductive health and PCOS, and how do you feel that medical nutrition therapy will help them to, improve their fertility outcomes and their weight management and minimizing the postpartum weight retention. So as you spoke about a healthy mother, so how can you start creating this healthy mother now?
Yes, so I think the point of concern now is the young girls, who are coming to us with PCOS. So that is a really concern point, because the problems what are they facing of infertility, that is a point of concern. But for PCOS, the only mantra is lifestyle modification. They have to follow a healthy diet. They have to follow mindful eating much when they are young. So I think we need to focus on young plumpy girls, that we need to tell all the mothers it's not having a very plumpy child. We need to have a healthy child. For these young girls, adolescent girls, we need to tell them to be physically active. They are mostly, as rightly said also by Cheryl, they are mostly seen on screen time, and with all the late night parties, with lot of alcohol and smoking intake. All these things are affecting the fertility of the woman. And moreover, all this sugar sweetened beverages, and there's a lot of things which collectively goes. So we need to have a lifestyle modification, especially for these PCOS women. So exercise is something what I really want to tell, and especially would like to tell all the mothers, do not make your girls princess. Make them physically active, So that's very, very important. And for that, I think MNT, your medical nutrition therapy, plays a vital role, because here this medical nutrition therapy, especially when we are talking about in pregnancy, it creates a healthy intrauterine metabolic and biochemical environment, because this is going to have an imprint in the future health of the fetus, and thereby it's a vicious cycle. So if we have a healthy baby, we are going to have the baby will also become a healthy mother. Or if you have an obese girl, so obese mother giving a birth to an obese child, again at their child, when they grow up, they will also tend to become obese. So this again is a vicious cycle which has to be broken. And now with all that, we also have to be very much mindful about the postpartum weight gain, because that again is a very big issue. The young girls stop eating. They want to lose weight immediately. But let me tell you that that when you are lactation, so lactation is not a period for any diet control or all. So once you are off the lactation, so here we need to focus that you need to come down to your pre-pregnancy BMI. And the best strategy is, I think, again, we need to adopt healthy dietary, healthy dietary habits. So again, focusing on your green leafy vegetables, good quality of proteins, that's your paneer, curd, milk and milk products, egg whites. Avoid your fast foods and your ultra processed foods, which rightly said that it's going to affect your gut as well. Your bakery foods, all these foods, the packaged foods, or all the high fat, high sugar, and high salt foods has to be avoided. Nevertheless, we need to adopt nutrient-dense seasonal fruits, and I think we need to focus more on the sleep. I mean to say sleep at a proper time, reduce the anxiety. There's a new word also coming, the anxiety panics in young girls. We never had anxiety panics, but I don't know why these people have these anxiety panics. So I think somewhere they need to indulge themselves into meditation, do yoga, exercise. That is very important. And come back to your pre-pregnancy BMI after your lactation period is over.
Yes, so well put, ma'am, that, focusing on yourself after your delivery, but not having unrealistic expectations is what we should be encouraging them. One take one day at a time, and I'm sure they're going to be reaching the goal of the pre-pregnancy BMI. Cheryl, so when now this woman has grown.
If it is normal, I'll just add to
Sure.
Sorry, I just wanted to add a normal pre-pregnancy BMI. It's like
normal pre-pregnancy, yes, that is important, because if it's a higher BMI earlier, then we are not serving the purpose. So, Cheryl, now that again, a very, very crucial period, I feel so, because maybe I'm going through it, but a perimenopausal and a menopausal period where, you're looking more of an emotional support and again, the hormones are changing. So what do you think would be the effective dietary and physical interventions which would help to reduce the effect of these hormones, and also reduce the central obesity at this stage when, exercise may become a little difficulty because with all the joint pain setting in, the fatigue setting in? How would you help these women in the perimenopausal or menopausal stage?
I think if I had, there is this thing, if you have to tell yourself something, if you were like 10 years before, I would tell myself to start strength training and eat right, because then that will reap its benefits later. And I always I teach the master students, I keep telling them, I'm like, this is the time to start. I wish somebody had told us. So I think if you really want good silver years of your life, you have to start young. And, strength training becomes extremely important. And of course, menopause, I think we all know, and we are in that perimenopause state. It's one of the most challenging, I think, mood swings, hot flashes. I think even in the winters, you're feeling hot. And I think very important is first is to tell the family members, because they don't understand what's happening. So love, care, and concern is very, very important. I think food is mood and mood is food. It both impacts. So when you feel those mood swings and then you reach out to all the unhealthy food that happens. So I think that's something that we need to focus on, is mindful eating, because there's a lot of mindless eating that happens because you're not able to sleep and then you end up eating all the unhealthy food. I think activity, keeping that 1 hour, doing something, whether it is Pilates or whether it is swimming or whether it is very important is strength training, because it does help, especially when you see that weight gain and the obesity, it does help. So I think somewhere, maybe getting a good trainer and seeing what your body can cope with. Sometimes it's just a mental thing that you feel you can't do it, So that is something which we really need to focus on. Looking at the calories, one is definitely cutting down the calories, eating good amount of protein, Mediterranean diet, which I think our Indian diet is pretty much like a Mediterranean diet. So more vegetables, fresh fruits, legumes, nuts and seeds. So, making sure, and of course, there are foods which have phytoestrogens, For example, you have your soya bean, you have flax seeds, you have, barley, rajma, which is again easily available in our kitchens. Again, when looking at the micronutrients, especially when it comes to magnesium, calcium, your vitamin K, vitamin D. So making sure that one is you're getting it through your food. So, nutrient density and diet diversity. So, you are able to actually inculcate or include these foods into your daily diet. You have a lot of seeds like pumpkin seeds, sesame seeds, chia seeds, watermelon seeds. Each one of them has a very good micronutrient profile, and it definitely helps when it comes to menopause and, all the symptoms that are associated. Then there are a lot of other things, like which contain isoflavones. For example, you have the red clover tea, the black cohosh. Then there is, evening primrose oil. So these are also things which will actually help in terms of lowering the hot flashes and, easing out the symptoms. And I think very, very important, at least because I'm facing it, I think very important is to talking to people and, who may have gone through it or who are going through it. I think that is so important, that whole kind of that peer support group, having that group, because sometimes you just don't want to go out. You just want to be in a shell just inside, because you're not feeling okay. But I think the whole thing is to talk to people. And because everybody, will then tell you that it's normal. It's not something that what you're going through, because you feel those depressive symptoms at times. There are a lot of those things which maybe your family does not understand. So I think it's important to talk to your friends. And this is where your school friends, college friends, really become your your mainstay. They have to be there and talk to them. And when it comes to the diet, of course, protein, eating a balanced diet, nutrient dense diet, including all these foods that we discussed about. I think these are important things to do, coupled with good exercise. I think most important is sleep. So what we would say is, again, 3-to-1 principle was at least eat your dinner 3 hours before. Try, again, people go on these extreme diets and they actually have only soup for dinner. And then they're so hungry that again in 2 hours, because they're not getting sleep, that is when all the unhealthy eating happens. So when you actually see their message in the morning, they would have eaten a lot of unhealthy food, is because they've eaten an early dinner and eaten a very light dinner. So tell them to have a very balanced dinner. It could obviously be lower in carbs, good amount of protein, so that will keep them full. And 2 hours before, at least stop doing any kind of stressful activity. If they're working or something, not to keep their mind too active and alert, because that itself can impede the sleep. And then 1 hour before, I know it's very difficult, but try and switch off from all devices, because the blue light itself will impede the, production of your sleep hormone, the melatonin, and that itself can impede sleep. So again, I've seen, at least personally in our practice, magnesium does help, so magnesium glycinate, if they can at bedtime. One is you definitely try and get it through food, like, from your nuts and seeds and all other foods, which are rich source of magnesium. But if that doesn't help, maybe a supplement could help, along with all the other things. And definitely no tea, coffee, caffeine, post 4-5 o'clock in the evening. And that could also help, because sleep becomes a big, big issue when it comes to this phase. I think staying connected.
Yeah, I think staying connected is the key word here, Cheryl. And I think though we would like to go on and keep on asking, in the interest of time, a quick one-liner from our panelists and even any other faculties who are still tuned with us would like to put in. We start with Neeta ma'am, then Kavita ma'am and Cheryl, and then anyone else who wants to just put in a word to us, most welcome.
Yeah, what I would like to say is that women go through a lot of changes in their life. At different stages, they need different kind of care, but they need care all the time. That when Cheryl said care and quiet during menopause, I was just thinking in my mind, I think we need it all the time.
All the time.
Yeah. So basically, based on the stage, I think HCPs have to come forward and actually formulate, kind of flash charts where we tell them. I mean, they're available in the West, but based on our ethnicity, we need to have puberty kind of guidelines. Then we need to have during the reproductive age what they can do to prevent obesity. So it could be a little different in each of these. Of course, there's a commonality in amongst all of these, but cognizance of the fact that different factors are at play needs to be emphasized. So prevention of obesity is the best treatment, of course. And that is what I would say. We need to do it differently at every stage.
Thank you so much, ma'am. Kavita, ma'am.
I think women are the main pillars of the house. They are the homemakers, the home managers. And here I would like to tell the entire family, the entire society should work harder, I think, to keep them happy and healthy. And moreover, one line I would just like to say that primordial prevention is important. We need to act today for a better tomorrow.
Thank you so much, ma'am. Sharon?
I think I would say make yourself a priority, because that's what we don't see. I think women, we are just inbuilt in that way. It's always caring for everybody else. And we have that guilt when we do something specifically. Even if we have to take out that 1 hour for ourselves, we feel that guilt. And I think that is most important. Like they say on flights, put your mask first before you go and help others. I think that's important. And what I do is something that I would, like other women maybe, who are listening here, is on Women's Day, what I do is I go and do my health checkup. So annual checkup is fixed for March, the first week, depending if I'm traveling. But I think that's very important. So, again, an annual checkup to see if everything is fine, and that you could keep that day, maybe your birthday or whatever, but, make your health and yourself a priority. That is what I would say.
Thank you so much. Points well taken. Thank you, my esteemed panelists, for joining me today. And now we quickly move on to the next session. Can we have the CV slide for Dr. Shalini, please? So now it's my privilege and honor to introduce Dr. Shalini Jaggi, a very close friend, and she's a consultant and director at Life Care Diabetes Center in New Delhi, fellow of Royal Colleges of Physicians of London, Edinburgh, and fellow of the Royal American College of Endocrinology, USA, and a national faculty, international faculty, and a very, very close friend. She's going to be talking about female sex as a window of opportunity to prevent NCDs. Over to you, Shalini.
Thank you so much, Ami, Dhruvi, and everyone else who's here. I'm here since the beginning, and I think this is such a great initiative that all of us have to take forward, because, when we have women speaking in favor of women's health, I think that is what is very important. Of course, it does not mean that men do not look after women's health, but the whole idea is we need to sensitize ourselves. And, I was just thinking, when we had an early a discussion earlier, how many of us actually undergo annual routine checkups? How many of us did a mammography? When did we do a mammo? When did we go for a basic pap smear? So I think when we're talking about women's health, we need to look inside and, actually first take the initiative and do something ourselves for ourselves, so that we can go to our patients with commitment and sensitize them on the importance of maintaining our health and prevention of NCDs. Prevention is very important. Treatment we all can offer. So, okay. So let me now share. Can I share my slides, please? If you can take this one off. I need to share. Can you please enable sharing for me? Okay, yes. Are my slides visible?
Yes.
Okay. So what I'm going to do in the next 20 minutes is introduce you to a concept that we've always been talking about, GDM as the mother of NCD. And let's take a step further, on how female gender probably could be the key to NCD prevention. We've all been talking about NCDs, the burden of diabetes, the burden of obesity, the burden of metabolic diseases. Where does it all start is very, very important. So what I'll do is we'll obviously start with what we've been talking right since the beginning of this webinar, the increasing numbers of women with diabetes and the increasing prevalence of hyperglycemia in pregnancy and GDM in our population. The importance of glycemic control, preconception to postpartum and thereafter. It does not stop only with pregnancy. It does not stop only with delivery. It has to be an ongoing process. We'll establish a link between GDM and NCDs. And then we'll also talk about how maternal health takes the center stage when we talk about NCDs. And we'll sum up I hope I will be able to convince this esteemed August gathering on how female health is the key to NCD prevention. So of course, this is something that we've been seeing. Number of women with diabetes is increasing. If you look at the statistics, yes, increasing at a very fast rate. And as the age gap between the men and women is bridged, as we mature, let me put it like that, of course the gap in the prevalence of diabetes starts narrowing. So by the time we are in our 50s and 60s, I think more of the women start getting diabetes even compared to men, and this is something which we need to acknowledge right from the beginning. Now, as the numbers of women with diabetes are increasing, so is the prevalence of hyperglycemia in pregnancy, as you can see here, all across the globe, with Southeast Asian region being right in the lead. 1 in 4 live births in the IDF Southeast Asian region are affected by hyperglycemia in pregnancy. And just about 2-3 years back, this used to be 1 in 6. So that's the speed at which we are increasing. And in India alone, GDM complicates nearly 4 million pregnancies annually, and now the numbers have gone up further. So when we talk of hyperglycemia in pregnancy, this is an umbrella term which engulfs all the different kinds of dysglycemia that you may see in pregnancy. So on the one end, you have women with pre-existing diabetes. It could be type 1, type 2, or any of the other forms of diabetes which has been diagnosed prior to pregnancy. And these women are stepping into pregnancy, which is pre-gestational diabetes. Or it could be women who are diagnosed for the first time with diabetes, having frank overt diabetes. That means they meet the WHO criteria of fasting more than 126 or post meals more than 200. But they are not aware of their diabetic status. So the test has been done for the first time in pregnancy, usually in the first trimester early on, and they are picked up as freeing diabetes. These are diabetes in pregnancy. And then you have the typical term gestational diabetes, which may occur anytime in the antenatal period, which is not clearly overt diabetes. And of course, usually GDM is not expected to persist postpartum, but the risk for diabetes remains. And I'm going to come to that in a little while. So now if you look at the global estimates of the different spectrums of HIP that I talked, 80% is attributed to pure gestational diabetes. 10% are women who've had pre-gestational diabetes, and about 9.1% are women who had frank diabetes but were not aware. And these are women who are picked up for the first time in pregnancy. So clearly you can see as the age goes up, the prevalence of hyperglycemia in pregnancy also goes up. Why it is important to have a very tight glycemic control is because by the time pregnancy is diagnosed, diagnosed in the sense it is picked up. So she misses her period, does a UPT, and finds out that she is pregnant. It's already 5 to 6 weeks. And look at the timeline of congenital malformations. They occur as early as 3 to 4 to 5 weeks. So she would not have even missed the period. But if the glycemic control is not optimum, if the A1C is on a higher side, spina bifida may have already occurred, and anencephaly may have already come, caudal regression may have already occurred. And that is why sensitizing them to checking their glucose levels pre-conception, to rule out overt diabetes if they do not have a history of diabetes, or if they do have pre-diabetes or pre-gestational diabetes, optimizing glycemic control prior to conception becomes very important. Because clearly you can see here, every 1% increase in HbA1c translates into a 30% increase in the risk of developing congenital anomalies. So that's one aspect. What happens if the woman already has pre-existing diabetes? Of course, pregnancy, the diabetogenic stress of placental hormones, the multiplicative rise in insulin resistance is going to worsen glycemia, push her into all these complications. And that is why we talk about preconception care, screening for complications, optimizing glycemia, optimizing lipids, optimizing blood pressure. And not only that, a child who is exposed to hyperglycemia in utero is the child who is at an increased risk of childhood obesity and diabetes in the offspring. And this is the NCD pandemic that we need to nip in the bud. Because when it comes to hyperglycemia in pregnancy or gestational diabetes, it is not only the problems in the index pregnancy. There's an increased risk of preeclampsia, all these complications, a difficult labor, cesarean section sometimes, all these neonatal complications of macrosomia, of metabolic complications that may occur in the baby in that index pregnancy. But postpartum and beyond, if the mother had GDM, the risk of recurrent GDM in the subsequent pregnancy or eventually translating into type 2 diabetes is very, very high. And for a child who has been given this intrauterine programming for diabetes, if this child becomes obese, risk of developing metabolic syndrome, type 2 diabetes, and the entire gamut of NCDs is very high. So the concern is GDM is essentially just a detection of chronic beta cell dysfunction that is occurring in a stress situation of pregnancy. So GDM is basically a stage in the evolution of type 2 diabetes that should alert you to the fact that this is the woman who is at a very high risk of developing diabetes, because the lifetime risk keeps getting compounded. Up to 50% of GDM women do develop IGT within 5 to 10 years of pregnancy. Tenfold risk of developing type 2 diabetes is very, very much present in women with GDM compared to women who do not get GDM in pregnancy. And then as time passes, the risk keeps increasing linearly. The story doesn't end here. Women with GDM are at a high risk of premature CVD, and we've heard our speakers talking about this. So suffice it to say that GDM is not only putting her at a risk of diabetes, but also cardiovascular disease. And this is very important because GDM is actually impacting two lives. Not only the mother who is at a risk of metabolic disease, but the child. The metabolic programming that can go wrong, predisposing this child to the entire gamut of NCDs, and therefore GDM gives us an opportunity for primary prevention of NCDs and cardiometabolic disorders. And this is not something that we've discovered today. If you go back to the ancient Indian evidence, at the time Garbha Upanishad was written, there's evidence of talking about the impact of how the child grows in the womb, having a kind of an impact on the child's life. And Acharya Chanakya in his Chanakya Samhita also talked about this, that in the womb itself, the environment of the womb fixes the destiny of this child. Not only the lifespan, the intelligence of the child, the physical health, the time of death may also be fixed. So this is clearly telling us that yes, there is something very important happening in pregnancy that needs to be addressed, that needs to be taken into very, very serious consideration. In our times, David Barker, the man who started actually talking about the concept of body susceptibility to lifestyle disease being programmed intrauterine, the famous fetal and infant origin of adult disease hypothesis. He actually, what did he say? What he said was that the programming of a child to develop all these NCDs can occur in utero. So exposure to a fetus in a critical period of development to all these adverse stimuli, it could be hyperglycemia, it could be malnutrition, it could be undernutrition or overnutrition. I'll show you that in a little while. All these adverse environments in the fetal life and early childhood will lead to an increased risk in adult life. So it's basically genetics which is loading the gun. And then when this child becomes sedentary, gains weight, this eventually leads to this pandemic of the epigenetic changes that occur. So definitely this leads to the all the plethora of adult diseases that we talk of. So gestational programming is a very important term. This is a process where stimuli such as hyperglycemia or stresses occurring at a critical or sensitive period of fetal development have a permanent impact on the structure, physiology, and metabolism of this child, predisposing this unborn child to all those adult diseases that we are talking of. So definitely, we all in medical school grow up reading the Pedersen hypothesis, which talks about excess glucose crossing placenta, creating a state of carbohydrate surplus in the fetus, stimulating hyperinsulinemia. And we know hyperinsulin is a anabolic hormone. So definitely the child is at a high risk of getting macrosomic, organomegaly, respiratory distress syndrome, polycythemia at birth. And now we have this theory by Norbert Frankel, which says it is not only carbohydrates, but all the nutrients, which in excess can be teratogenic. in the sense that fuel-mediated teratogenesis may be the basis for long-range anatomic and functional changes in the fetus. So basically, it's not only the carbs, but also excess nutrition in terms of excess fat consumption, increased proteins and carbs mixed together, which cross the placenta, creating a situation of hyperinsulinemia. So the fetus not only has a high risk of developing macrosomia during pregnancy, but once this child is born and becomes obese, there is a very high risk of NCDs, metabolic syndrome, IGT, diabetes, and cardiovascular disease. Now, where does the female gender come in? Well, I told you, if this child is a male child and he has been exposed to hyperglycemia and the fuel-mediated teratogenesis intrauterine, of course, this child may be born macrosomic, may develop neonatal hypoglycemia or other complications, but once this child starts growing up and becomes obese, he has a high risk of IGT and then eventually transforming into diabetes, and that's it. But if this child is a female, what will happen? This female is getting obese. She again becomes at a high risk of GDM when she gets pregnant, thereby eventually turning into diabetes, and the vicious cycle of diabetes begetting diabetes continues. So this is where it becomes very, very important to understand that there is transgenerational transmission of NCDs that is occurring, and therefore it is necessary to target the health of a female to stop this vicious cycle. Now, NCDs adversely impact maternal health, and poor maternal health increases the risk of NCDs, and this is where we need to intervene. So be it maternal overnutrition, which is leading to an increased risk, which alters the physiology through the epigenetic changes that are occurring, increasing the risk of obesity, diabetes, and CVD in the offspring, or it is maternal undernutrition. There also the adverse fetal programming as a result of hypoxemia, metabolic changes, endocrine changes, and can again lead to an altered fetal programming, predisposing this child to an increased risk of diabetes, cardiovascular disease, and obesity as this child grows up. So there's a clear link, be it maternal undernutrition, Barker's hypothesis, catch-up growth, child becomes obese, or be it Pedersen hypothesis, maternal overnutrition, fuel-mediated teratogenesis, the child being macrosomic, overweight. Birth weight is a very important predictor for future risk of type 2 diabetes because it's a U-shaped curve. So having a child with optimum birth weight is very, very important. The Doe-Had hypothesis again talks about these environmental exposures leading to epigenetic modifications in the child, and once this child grows up, becomes obese, the whole trajectory of NCDs can start. So clearly you can see that intrauterine environment is very important, not only because of the anatomical malformations that may happen if the child is exposed to hyperglycemia in early pregnancy, but as the child grows, hypothalamic dysfunction, obesity, delayed neurocognitive development, neuropsychiatric disorders, anxiety, neurodegenerative diseases also may be primed right in the womb. So a sterile inflammatory result in GDM, if the glucose levels are not well controlled, may lead to dysregulation of the expression and activity of various signaling pathways in the placenta, in the adipose tissue, and in the skeletal muscle, creating a state of plus endothelial dysfunction, enhanced inflammation, and insulin resistance, which predispose this offspring not only to being born overweight or macrosomic in short term, but eventually growing up to be an obese kid, a child who has metabolic syndrome, and eventually developing diabetes. And that is why we see diabetes happening so early. So friends, GDM plays a very important role in increasing the prevalence of diabetes and obesity. We know it is the mother of cardiometabolic diseases, and therefore this highlights the fact that optimizing the female's health is the key to stop this avalanche of NCDs. Suboptimal in utero environment has its effect on all the organ systems, as you can see here. Even now we know that asthma, COPD, wheezing may also have its origin much earlier. Functional defects and mechanisms may occur even in a woman who has GDM. I'm not even talking about the major morphological abnormalities, the disruption in organogenesis that may occur in pre-GDM if she's not controlled. But look at this, even in late third trimester, Alveolar sac formation may be affected, surfactant production may be affected if glucose level is not under control. And thereby, these children may not only be born with respiratory conditions, but may eventually develop chronic lung diseases like wheezing and asthma as they grow up. So when we talk about prevention of diabetes, it should not start only once she gets GDM or she's delivered in terms of postpartum care. It has to start in the preconception period, even in the intrauterine period, to control glycemia so well. So it offers us an important opportunity to recognize that development, testing, and implementation of clinical strategies for diabetes prevention has to start much earlier. Because I showed you this U-shaped graph. So the solution is optimum intrauterine environment, optimal birth weight. So friends, female gender does seem to be the key to diabetes prevention, because both low birth weight and large for gestational age predispose these children in adult life to an elevated risk of obesity, diabetes, hypertension, CVD, the entire gamut of NCDs. And this intergenerational transfer of risk needs to be capped by optimizing maternal health, which is a very, very important link to this entire NCD pandemic. Therefore, pregnancy gives us a window of opportunity to provide maternal care services to reduce the traditional maternal and perinatal morbidity mortality indicators and address the intergenerational prevention of NCDs such as diabetes, hypertension, cardiovascular disease. So as clinicians, we have this rare opportunity to alter the natural course of disease. Right when she is a girl, PCOS, obesity, all these need to be addressed. If she has a family history of diabetes, it is all the more important to sensitize her on the importance of preconception checkup, preconception control, so that pregnancy happens to be a smooth and a positive experience for her, and the child in the womb is not programmed, is not exposed to any of the adverse stimulants that I talked about. Because to understand and intervene and alter the natural course of disease and change the future health of women and their offspring today. So friends, I hope I have been able to convince you that GDM gives us a window of opportunity for prevention of NCDs. And this is where female health is the key to NCD prevention. And like Professor V. Seshia, the father of GDM in India, says, to achieve a diabetes-free generation, we need to focus on the fetus for the future. So this is a very important take-home, because preconception, postpartum, the care has to be ongoing. It cannot stop. You cannot put it in silos of, looking after her glycemia, looking after her health at a particular stage. It has to be a lifelong process. Thank you so much.
Thank you. It is such a privilege to be hearing about women health from the president-elect of DIPSI, from the chair of RSSBI Delhi chapter. And Delhi is ruled by women across medical and non-medical arenas.
I'm so happy we have a woman president sitting in Delhi. Our country is ruled by we have a female president. So it's definitely a privilege to be in Delhi at this time.
So way to go. You have actually convinced us, ma'am, that why taking care of females is primordial prevention and the most important factor for prevention of NCDs. Thank you so much, Shalini ma'am. Just one question just up from the audience. We are having 462 logins, which is such an overwhelming number, overwhelming for all of us. Kudos to all the faculties, all the panelists, Ami ma'am, Shalini ma'am, Shefali ma'am, Purvi ma'am, Kavita ma'am, Cheryl ma'am, everybody, all those who have given, their entire heart and soul to the program right now. Shalini ma'am, the question from the audience is, how do you execute this strategy that you are talking about? If you have to give us 3 messages to the people listening right now, what would be strategies if you want to place across for executing what you just told us?
Number 1, all adolescent girls have to be sensitized to the importance of weight management, sugar management, even if they do not have diabetes. Everyone has a family history, I'm sure. If not a first degree, at least a second degree relative does have diabetes. We Southeast Asians are born with those genes, right? So I think sensitizing them to the importance of maintaining their weight, preventing diabetes. If they do get diabetes, optimum glycemic control, the importance of planned pregnancy. Exercise, nutrition has to be part of it all along. Preconception planning is very, very important. Every young woman with diabetes coming to your OPD has to be told this, that even if you get married tomorrow, whenever you get married, whenever you plan a baby, you need to have optimized health. Talk about the dangers and the risks associated with uncontrolled diabetes, risk of obesity in pregnancies, and independent obesity is an independent risk factor again, PCOS, all of these. So I think telling her to maintain an optimum weight, an exercise schedule, eating right, mindful eating is very important. Somebody who is planning a pregnancy, who is in the reproductive age group, preconception diabetes control, HbA1c less than 6.5%. Very, very important. Review of medications. There's an entire preconception. I can, it's an entire session in itself on preconception counseling. But like I said, A, B, C's. A1C, blood pressure, cholesterol, and weight. Very, very important. So all these have to be managed. Screening for microvascular complications. We know there's aggravation of retinopathy if there is pre-existing retinopathy. We know there's aggravation of neuropathy if she has pre-existing neuropathy. Similarly, nephropathy. So I think screening for microvascular complications, especially in all young girls with type 1 diabetes who are getting married, who are going to get married and plan pregnancies, this becomes again very important. So start talking about it before that. Not once she gets pregnant and then you are in a big rush to control glycemia. Woman with type 2 diabetes, she needs to stop the oral drugs. Very few drugs, only metformin now DCGI has approved for pregnancy. Besides that, none of the drugs is approved. So switching her to insulin pre-conception, continuing insulin all through pregnancy, plus minus metformin based on the woman's condition. And then even when she's lactating, most of the drugs are not indicated in lactation. They're also continuing insulin if there is pre-existing type 2 diabetes. Type 1, obviously, basal bolus has to continue. So all these important steps. Oral drugs may be transitioned once she stops lactating. So the important point is preconception, postpartum follow-up. When they are pregnant, they will follow everything that you tell. Even when they come to you with GDM. The moment the baby is born, 2 months, 3 months down the line, they get busy looking after the child and everything goes for a 6. Gestational weight keeps piling up. So the risk of recurrent GDM in the subsequent pregnancy and then eventually transforming into type 2 diabetes is again very important. So screening, first point, ideally the screening should be preconception, but if that has not been done, at the first point in contact, when she comes to you, when she's just done a UPT positive first trimester, she's coming to you or to an obstetrician, a simple DIPSI test or an IID-PSG, whatever. DIPSI is so clearly now being done everywhere across the country. Screening for gestational diabetes in first trimester. If that is negative, again in the second trimester. And if that is negative, again in the third trimester is very important for all our women. Indian women are at an 11-fold increased risk of GDM compared to the Caucasian women. So all the guidelines that apply to the whites may not apply to us. So, the DIPSI document talks about it very beautifully. I think it's important to screen all the women at the first point in pregnancy and then every trimester thereafter for gestational diabetes. If you pick it up, optimized management, tight glycemic control during pregnancy, fasting between 70 to 90, 2-hour value less than 120. That's the target. No compromise there. Only if she's a type 1 who's getting too much of hypoglycemia by intensifying insulin, you can increase the fasting to about 110 and the post-meal till about 140, not beyond that. Because now there is a concept of primordial prevention, which tells you that there's something called maternal glucose steal. So if it is somebody who is obese, she already has insulin resistance. So the islets start producing insulin by about 7 to 8 weeks. So if you've not screened her before that time, by the time she is 10 to 11 weeks, there is already insulin production occurring. So even if the glucose levels go up, the fetal insulin will take over. So the maternal glucose will still be normal. So if you do a test later, she may still have a normal glucose test. But this is where the priming has already occurred. So the horse has already bolted by the time she's 10 or 11 weeks pregnant. So now we're talking about testing much earlier. So like I said, first time in pregnancy, 6 weeks or 7 weeks is the optimum time to actually do the first screening for GDM and then accordingly manage and do it subsequently.
Thank you. Thank you so much, ma'am. It is important, and that is why we are having such programs, such faculties like yourself. Thank you. Thank you so much. We've had wonderful time listening to you. I will now request and move on to our next speaker, Dr. Shefali Karkhanis. Can I request the RX team to put up her CV slide? Dr. Shefali is a senior clinician diabetologist from the city of Mumbai. She has been a speaker at multiple national and international congresses. The RX team has very happily and very timely put up her CV slide right now, and I'm so happy. She's the founder and co-director of the Karkhane Super Speciality Hospital, Thane. She's got multiple fellowships. She's a SCOPE certified clinician for management of obesity, and she's a member of a lot of organizing committees for conferences. So with that, I'm going to request Shefali ma'am to take up her talk today. Thank you, ma'am, for accepting
Thank you so
our
much,
invitation.
Dhruvi and Ami. Because I have been just silently listening through all the previous topics, and you've both done a fantastic job. Fantabulous. Congratulations to both of you. So if I can share my slides.
Yes.
So I have been given a very interesting topic actually, and thankful to both of you for that, because we have only been talking about everything else other than glucose. Nowadays, wherever you go, it's all about cardio safety, renal safety, retinol safety, etc., etc. But we have forgotten that glucocentricity is actually the crux of the matter. So we have a huge population. We are the diabetic capital of the world. 463 million adults worldwide living with diabetes, and 50% of them are women. In fact, 1 in 10 women will probably be living in diabetes, and this is an approximation from 2019. So after COVID, I'm sure the numbers are even worse. So formerly, where glucose was our only target, we are now talking about hypoglycemia, we're talking about CVD, we're talking about renal aspect, the muscle, the mental health, obesity, everything comes into the picture. But I would like you to, the ADA, EASD, everyone is talking about cardiorenal protection, the CV factor risk management, and how we can bring down the complications. And we are forgetting the basic thing, the progressive nature of diabetes. So if you see, we are all sure, I'm sure all of us have read this chart in our MBBS days, where the pre-diabetes starts and the beta cell function starts decreasing and the insulin secretion starts coming down and resistance increases, etc., etc. But the crux of the matter is where the macro and microvascular complications start at the time of diagnosis or even before. The problem here is the glycemia. So we need to take into consideration how our glycemic control is going to affect the complications. So if we want to reduce the cardiovascular incidences, if we want to reduce the renal problems, we need to get our glycemia under control for our patients, because poor glycemic control is what causes the complication. And even in the pillars, this is a famous figure which we've been seeing all throughout. The first pillar of management for type 2 diabetes is always glycemic management. And somehow I feel, at least the patients that I'm seeing through, coming from other doctors, the glycemic management has taken a backfold, and people are now looking into HSCRPs, we're looking into cardiac evaluation, looking into renal evaluation, etc., which is just as important, not taking anything away from that. But glycemic management has somehow taken the back foot, which is not right. So what is glucocentricity? Glucocentricity refers to treatment approach primarily focused on the controlling of the blood sugar levels in diabetes management. And this is achieved with various purposes. And unfortunately, from India, although we are the diabetic capital, a significant number of people are still uncontrolled. The UKPDS has clearly showed that early intensive glycemic control minimizes the lifetime risk of diabetes-related complications. the concept of metabolic memory has been drilled into us by the DCCT and the EDICT studies. And the legacy effect, which is so clearly established, that just 1% drop in A1C also benefits the patient when they are newly diagnosed. So if you see the intensity of control within 1 year of duration of diagnosis of diabetes, bringing the HbA1c down to 6.5 or less reduces not only the microvascular complications by 40%, but also reduces the macrovascular complications and death by 30%. Now, this is a huge number when you consider the number of diabetic patients that we have in India. And hence, reduction in A1C should be a primary motive as far as patient with diabetes is concerned. Glucocentricity is a cornerstone of type 2 diabetes management. So 1% drop in A1C can actually reduce the long-term complications, 12% reduction in diabetes-related endpoints, 16% reduction in myocardial infarctions, 21% reduction in retinopathy, 33% reduction in albuminuria. So the positive effects just don't come down. They are always going to be positive. Now, when I was learning, it was always fasting, PP, and HbA1c. This was the glycemic triad. Then we went to the pentad, where we had the hypoglycemia and the nocturnal hypoglycemia added. And now we also have glycemic variability. Since we are living in a age where we have so many options at our hand, we can put a CGM, we can subject the patients to different kind of tests. And that is where this concept of TIR has come into the picture. What is seen and published over and over again is that subjects who have spent 50%, less than 50% of the time in range has shown increased chances of micro and macrovascular complications. And just 10% increase in TIR from whatever they were at initially will actually reduce the severity of all the complications. And this gives us a very important aspect about how we can actually manage to control the patients on patients with diabetes. So initially, when we used to do an A1C alone, which is a very good indicator for sugar control, but it is not optimum, because if it is combined with a glucose variability with a CGM, it can actually give us a very fair picture, a very good idea about how the sugar varies in every patient with diabetes. This is even more important in our Indian scenario, because as we were learning to Cheryl and Dr. Kavita, we are a high carbohydrate consuming country. In fact, 70% of our total caloric intake is from carbohydrates, mainly consisting of wheat and rice. And along with this, we have our genes. We have a very high prevalence of insulin resistance. We are susceptible to metabolic syndrome. We are living a sedentary lifestyle. Our sleep cycle is very much disturbed. And all of this makes us susceptible to have uncontrolled sugars, which will finally translate into uncontrolled complications as well. So going back to the basic slide, we must consider that along with hyperinsulinemia, there are a lot of other factors which come into picture, including the genetics, the weight gain, the dyslipidemia, the hypertension, and of course, the insulin resistance. Now, unfortunately, fortunately, we are all women. We are very special people. But unfortunately, the lifespan of a woman and insulin resistance is very intimately connected. Take a young girl. A young girl who develops diabetes, whether it is type 1 or type 2, faces a lot of complications, not only due to the hormones, but also psychological, also physical. So Indian data puts the prevalence of prediabetes and diabetes at 8.4 in adolescent girls, with obesity and overweight being the most important predictor of the disease. Now, there's a lot of interplay of pubertal hormones, because growth hormones, sex hormones, etc. will increase the insulin resistance. And this will further worsen the control of diabetes. Again, a presence of PCOS and obesity will worsen diabetes. We were talking about how people are not going down and playing, but playing with their thumbs. So this again increases the obesity, and obesity will further reduce sugar control. Conversely, diabetes also causes hormonal imbalance. So it causes irregular menses, it causes other endocrine disorders. In fact, the Today study has shown that menstrual dysfunction is very common with girls who have been diagnosed with type 2 diabetes recently because of changes in the sex steroids, AST levels, etc. And all of this will have a psychological impact on the young girl. She is aggravated. She's already having a body dysmorphic syndrome. She has to closely monitor her sugars. She has to have dietary restrictions. She has to say no to accepting certain kind of food in front of others. And this leads to depression, low self-esteem, and eating disorders. And this further worsens the diabetes and vice versa. If you talk about the middle age, now this is a very beautiful age in the life of a woman, because there are a lot of things that can happen, in the sense that the girls are now working. They become financially independent, they get married, they have children, and they build up a home. But there are a lot of lifestyle changes which are involved, because there is increased stress. She has to now manage whatever was done by her mother has now to be managed by her. In fact, having a work and work family balance is very difficult for a woman. Even in today's day, when people are working for 15 hours and 14 hours in a day, they still have to do the housework. And it's in certain areas, yes, it's the work is divided, but most of the time the women is the one who has to work in the house as well, in spite of working outside. And this actually increases her stress, which will increase her chances of getting diabetes as well. In fact, many of the times, patients who have diabetes in early stages do not get a proposal for marriage. And this is seen even in literate states like Kerala, where they do not accept people who have already got diabetes. And therefore, that also adds to the mental torture and mental pressure. Once you start working, well, there is only physical inactivity. A person who was a sports person earlier, national level champions, will now sit on the front of the computer and work from the chair. There are a lot of physiological changes which take place, including pregnancy and menopause. Weight gain is very, very commonly seen, especially after the woman gets married. Hyperglycemia in pregnancy, we've heard about it from Shalini, and I'll talk about it in a short while. Primary and secondary infertility is very common, especially in patients with uncontrolled diabetes, especially in advancing age. Nowadays, girls get married later and later on in life. So primary and secondary infertility is very commonly seen, probably because of the hormonal changes, especially when the sugars are not under control. Perimenopausal women have a different challenge, because there are a lot of interplay between the hormonal changes and the metabolic health. So once you reach the perimenopausal stage, the estrogen will start affecting the glucose homeostasis via the estrogen receptors and the GLUT4 hormones. The SWAN study has suggested that lower estradiol concentrations will up the risk, will result in 47% higher risk of getting type 2 diabetes during a menopausal transition. Again, there is an increased risk of developing complications and type 2 diabetes and uncontrolled type 2 diabetes, as I'm sure we all see in the practice, probably because of the male hormones coming into picture, the testosterone, the androgen levels, all of these start going higher, and the ratio between the estrogen and the male hormones actually changes, causing imbalance in the metabolic milieu of the patient. Menopause is a potential risk factor for developing insulin resistance independent of the age. And hence, it must be taken into consideration for every woman who's above 40. We must ask the patient to, actually look for and check for the sugars much, much more often than what she was probably doing in her younger days. Post-menopausal years, there is a chronic diabetes is obviously will accelerate. There is a decline in the hormones, so the resistance will increase. It accelerates vascular and cellular aging. There are several clinical trials which have shown that there is reduction in the estrogen levels, which leads to a low-grade inflammatory state. thereby precipitating insulin resistance, causing a significant endothelial dysfunction, thereby putting the patients at risk of developing CVDs and CKDs. The patients who are postmenopausal also have sarcopenia, have osteoporosis. They can have a cognitive decline. They are more dependent on the male family members for their drug intake. The financial independence is probably lost in the older age. Our NRI parents are really suffering nowadays, and all of this will hamper the effective management of type 2 diabetes. A few slides about hyperglycemia in pregnancy. As Shalini has rightly mentioned, the prevalence rate in GDM is estimated to be about 10 to 14.3, and we Indian women are at 11-fold increased risk of developing GDM. The prevalence of gestational diabetes increases with age, and with increasing age of marriage, again, this is going to be a big factor. As we know, glucose tolerance develops when the balance between the insulin secretion and the demand for insulin is not met. Pregnancy is like a marathon for the female body, and the insulin resistance peaks during pregnancy. If the beta cells, which are already failing, are unable to meet the demands of this excessive need, then obviously we'll develop gestational diabetes. And we know that it has a lot of effects on both the mother as well as the child. Therefore, we have very strict glycemic targets during pregnancy. We have to maintain the fasting levels of less than 90. We have to maintain a postprandial levels of less than 120. Ideally, maintain an A1C of less than 6 all throughout the pregnancy without causing hypoglycemia. A point to be noted here is that during pregnancy, the terms of hypoglycemia are also altered. So 70 is not a hypoglycemic event unless the patient is symptomatic. Now, if you consider why are we paying so much of attention to glycemic targets, that proves that glucocentricity is finally the crux of the matter as far as patients of type 2 diabetes or type 1 diabetes are concerned. Shalini has also spoken about how the consequences of offspring being exposed to maternal GDM throughout his lifetime has a different programming or transgenerational programming that can occur within the patients, with a vicious cycle of diabetes leading to a young woman at risk or having diabetes will become GDM, and hyperglycemia in pregnancy will have an infant who is then predisposed to developing diabetes in future. Now, as I said, we women are very different, and we have a different set of problems while managing diabetes. So hormonal impacts, we've already spoken about: estrogen, progesterone, the menopause, pregnancy, etc. But what is to be considered is women with diabetes have 3 to 4 times higher risk of developing cardiovascular diseases as compared to patients who are non-diabetic. We also have a unique emotional and psychological burdens. Therefore, the prevalence of diabetic distress and depression in women with diabetes is much higher. And of course, the nutritional status in our country is not very good as well. There are a number of patients, even from affluent society, who have anemia, vitamin B12 deficiency, vitamin D deficiency, micronutrient deficiency, macronutrient deficiency, and not all of them are open to receive and treat themselves with different kinds of nutritional supplements, and hence they land up in having bigger problems. If you talk about barriers in diabetes control in women, the therapy itself is a big thing, because the cost of the medication is also always in the mind of the women. The regimen complexity is important because the women are always more attentive and vigilant about what the husband will be taking rather than what they are taking. There are always, the social media is always there to change the patient's perception of medicines and its side effects, and how the misconceptions, all the misconceptions about diabetes and its medications are all there for everyone to see who wants to see it. Family support or lack thereof is very, very important as well. There is peer pressure, because every time a patient, a person, a female goes into a gathering, there will be 10 women telling her that don't worry, you eat this right now, this is only one time affair, and then you go and have something, some jadi booty, and this will cure everything that you have. Sorry. There are a lot of stress and emotional problems that a woman goes through on a daily basis, right from something as simple as aaj pani kab aayega, to something as important as how is the health of my child. So we have been trained to be self-sacrificing. Irregular meal timings are one of the biggest important issues as far as I am concerned when I'm treating women with diabetes, because they will want to feed everyone in the family before they can take a morsel themselves. And this irregular meal timings makes it very difficult for control of their blood sugars. And we have festivities, we have fasting, we have feasting, and this fasting, Mahashivratri, every woman that I know after Mahashivratri has consumed a lot of sabudana and not taken medications because I'm not eating anything. So there is a lot of misconception and misnomers that go on as far as women and diabetes control is concerned. There is a negative connotations as far as diabetes is concerned, and a diabetes is often viewed as a flaw or a weakness. There is therapeutic inertia, not only on the physician's part, but also on the part of the patient, the lady, as well as their family members. Poor medication adherence is very commonly seen. Availability and access to medications is an important barrier, especially in the lower and middle income societies. Underplaying of the symptoms, ignoring the signs, postponing the test, doctor's visits are postponed. Failure to self-prioritize is often seen in women. We have an array of molecules at our disposal. The RSSDI wheel is actually a beautiful tool to start medications early. There are different medications which are available which can target different pathologies of sugar. We just have to have patients who are open to use it. So I think I have clearly said that glucocentricity is very, very important, because only and only if you have good glycemic control, you can minimize complications, you can prevent mortality, and you can reduce morbidity as well. We need a personalized, evidence-based, cost-effective care for each and every individual that walks into our clinic. The aim is intensive glucose lowering as soon as possible, right at the early stage, and then sustaining that glycemic control rather than stepwise escalation or de-escalation, and then finally culminating into a multi-organ management. So I would just end my talk saying that it is very important to control glucose. That is the first thing that we need to do for every patient. But at the same time, we need to also think beyond glucose control and act early in order to protect the kidney, heart, brain, and of the patient. Not just for the men, but also for the women. Thank you very much.
Thank you, Shefali ma'am.
Yeah, so thank you so much, Shefali, for this wonderful, wonderful presentation. You're emphasizing every point so clearly that a good glycemic control is going to take you to places where we talk about other problems, but the bottom line is a good glycemic control. So as treating diabetologists, I think that is our primary goal in all our patients who enter our chamber. So over to Dhruvi. Thank you, Shefali. Thank you once again.
Thank you so much, both of you.
Thank you, Shefali ma'am. Thank you. It has been such a wonderful last 2 hours. It's so, heartening to see such a lot of support. The idea together was to have a group of women talk and advocate about women healthcare, and who better than the people who were there together today. We've got such wonderful panelists, such wonderful talks, such wonderful faculties. coming together to talk about how Shakti can make a difference. When we all come together, we can be a very strong force to make a difference in the life of women with any of the non-communicable disorders, be it diabetes, obesity, hypertension, dyslipidemia, and there's more. Just a 2 hours program talk once in a while is a very small stone. Of course, it is impactful, but it is just the beginning of a lot more things that we should plan and we should be executing. With that, I want to thank all my faculties today, starting from Dr. Shalini ma'am to Purvi ma'am, Shefali ma'am, Dr. Cheryl, Kavita ma'am, Neeta ma'am, Archana ma'am, Dr. Manisha, Lautika ma'am, Dr. Nandita, and just telling them all of these names have been such wonderful. But my biggest thank today goes to Dr. Ami ma'am, who made sure that we did this. It just budded with an idea 2 weeks ago that chalo, we need to do something. It's just Women Day coming, and thanks to her for pushing and making this happen. She's got a huge role to play in the execution, in the planning, and in the organization of today's program. So thank you to Dr.
I think
Rami.
it's an equal thing, Dhruv.
Thank you so much. Shalini ma'am is here, Shefali ma'am is here. I think
They have been big pillars.
Big pillars, huge
Sent out
people.
pillars.
Exactly. And it's
we are the kidney and the heart and etc. You both are the glucose control. Let's put it that way.
Absolutely no. It has been a great event, and I think now that we've kickstarted it, we should make it a regular event. Let's keep the conversation going on different aspects of women's health. So I think let's not just make it a Women's Day to Women's Day event. Let's make it a seasonal event, and let's probably have a discussion maybe every month with all our group together and create more awareness on women's health and all the different aspects that we need to discuss in detail.
Absolutely. So more Shakti to you, ma'am. More Shakti to us, and more
Absolutely,
Shakti to everyone.
to all of us. More Shakti to all of us. And thank you, Ami and Purvi and Dhruvi, for organizing this entire event. It's been a pleasure. I've been glued to it right from the beginning, and you can see me driving home, but I'm still glued to it.
No.
Awesome idea. And let the Shakti continue blessing us and giving us more power to take it forward.
Yes,
And
thank you.
let this
Thank
be
you
an
so much.
ongoing event. Let this be an
Absolutely.
ongoing event, and we're all there in it together.
Ma'am, it's all our platform together. We women have to stick together, stay together, and be brilliant as much as possible, and not let anyone tell us otherwise. So thank you for always being there. And it's like hashtag womanhood, hashtag sisterhood, hashtag to women health everywhere, and let's just stand by each other. Thank you to each and everyone. I might have forgotten somebody, I'm really sorry, but thank you to the USV team for being our solid partners today. Thank you to the RX team for being our technical partners today. And once again, thank you to the Almighty. He made us capable and made us realize of what our capacities are. So with that, thank you so much to everybody logged in. Thank you for listening to us, and trying to spread the message that we are advocating today. Thank you so much.
Thank you.
Thank you. Thank you. Bye-bye.
Stay blessed. Bye-bye. Thank you.
Bye.
Bye.
RX, you can stop the recording, please. Yes, now it's just you and I, Ami ma'am.
Yeah.